and we will dig right in to Chapter 14, Bleeding, Shock, and Soft Tissue Injuries. So again, when we look at the National EMS Education Standards, we see that this is going to cover a bunch of different areas of knowledge. So anatomy, physiology, and pathophysiology. And again, patho refers to anything that is broken or not normal. So it's the physiology, which is the functioning of the body, and pathophysiology is the function when it's broken or the dysfunction of the body. So we need to, again, simple knowledge, apply simple knowledge and simple theories to figure out what's going wrong with our patient. And then once we figure that out, we need to apply appropriate treatment. And so what we're going to focus on tonight is what we call shock, which will explain what that is, and resuscitation, which is what you do for someone in shock. And this is all relating to trauma. Again, these are broad topic areas, and we're going to get into the nitty-gritty here with regard to bleeding, specific injuries to head, neck, face, and spine. We're going to talk about chest trauma, which is fascinatingly complex. Abdominal and genitourinary trauma, which like all of the guts are in your abdomen. It is just a labyrinth of mystery and torment in there. And so we're going to, again, skim the surface of that. We're going to get into soft tissue trauma, which is the stuff on the outside that we can see. A lot of the interventions are very, very similar to one another, but we're going to sort of get into what you're going to find and what your general approach is to treating it. And then, of course, multi-system trauma, because the textbook case is the textbook case because it's simple. It's in isolation. It is uncomplicated and easy to understand. I would say that anyone with some years behind them would tell you that life is not uncomplicated and easy to understand. Pretty much everything we encounter in the real world is complicated and difficult, and trauma is the same way. And so multi-system trauma is sort of the culmination of all these various soft tissue injuries and thoracic and abdominal and head, neck, and face trauma all together, because when we're pulling someone out of an upside down car, that's what we're going to find is a multi-system trauma. So this is pulling it all together. And then finally, we have a little bit of medicine. Medicine touches everything that we do because EMS is a medical field. And so we need to know a little bit about medicine. And so where are we going to touch on this? We're going to talk about some anaphylactic reaction, which a little bit about immunology. We're not going to get too into depth there. All right, so in general, EMRs need to be able to recognize and care for patients who are suffering from shock, bleeding, and soft tissue injuries. And what's really going to pay you dividends here is good adherence to standard precautions. It's really important when you're dealing with trauma patients, especially bleeding, coughing, sputtering patients. The damage to internal soft tissues and organs can cause life-threatening conditions. And we see that in the form of internal bleeding, which causes the patient to lose blood from the circulatory system into the tissues of the body, which can result in shock. And then we're going to talk about the shock state, which is a state of collapse of the cardiovascular system, which results in inadequate delivery of blood to the organs. So the amount of oxygen that we're delivering does not meet the oxygen demand of the tissues, and that's where we see shock. And more trauma patients die from shock than most other conditions. We see that about 30,000 patients in a normal year, 30,000 patients every year die from bleeding that could have been controlled by simple first aid. So, like, we're talking basics. 30,000 people every year die. Now, in light of COVID and, 300,000 or 600,000 people dying, like, it doesn't seem like a lot. But hey, we do what we can. That's 30,000 people that didn't need to die that are dead because simple bleeding control measures weren't enacted. So what we're going to do tonight is we're going to teach you how to gauge the extent of injury and how to appropriately apply interventions. So again, fundamentals here. This is the same sequence that we've been practicing all along. This is what we our first skills session, we did scene size up and primary assessment. This weekend, we're going to get into a sample history, secondary assessment, and some other stuff. This is your approach. This is your systematic approach to every single patient. And while we change it up a little bit, we take secondary assessment and put it before history taking in a trauma patient, you're still doing all the same steps. And we're going to talk a little bit about that and why that happens. So it's important to follow these steps when caring for any patients, whether they're bleeding, in shock, have soft tissue injuries, or are complaining of something else. The scene size up needs to include all the steps you've previously learned to ensure the safety for you, your crew, the patient, and any bystanders. And when you're performing the primary assessment, you need to temporarily halt the assessment if the patient is losing a significant amount of blood. So remember, when we talk about looking for life-threatening conditions, again, so that's general impression, level of consciousness, and evaluation for life-threatening conditions during our scene size up. Bleeding to death, obvious life-threatening bleeding is a life-threatening condition. And so we're going to stop that, and we're going to intervene with some kind of bleeding control measure, right? And we'll talk about what that looks like. And then during the secondary assessment, be alert for any signs and symptoms of shock from internal or external bleeding loss, and we'll talk about what shock looks like. When obtaining a sample history, you can ask the patient whether they have been using medications that cause them to bleed, what we call blood thinners, which may interfere with blood clotting. For trauma patients, you'll usually perform the secondary assessment before you obtain a sample history, because think about it. What's more important? Finding out all of the places that they are bleeding from and stopping that bleeding, or asking them what they ate for lunch? Right? What is physically more important? And the answer is obviously, because I saw some people laughing there, the answer is obviously we want to go head to toe in a systematic manner and find everything that's broken about them and start fixing it. And then we can ask the questions like, what are you allergic to? Well, obviously you're allergic to driving your cars into trees because you break out in spontaneous fractures everywhere, right? So we need to maintain your clinical curiosity, but make sure you prioritize sort of the important physical aspects of this. So when you're performing a reassessment, watch the patient for signs of impending shock. So we're looking for their skin to appear paler or grayer. We're looking for changes in their vital signs. And so we're going to start taking vital signs this weekend. So we're looking for increasing heart rate, and then eventually a decreasing blood pressure if it gets bad enough. And so again, we'll have plenty of practice doing that. So standard precautions. The concept of standard precautions assumes that all body fluids are potentially infectious. And so we want to take appropriate measures to prevent contact with the patient's body fluid. So we're always going to wear gloves when we interact with patients, and especially if the patients are bleeding. But we're also going to consider the need to wear a surgical mask, to wear eye protection like goggles or a gown if we want to go that far, especially if the patient is coughing blood or vomiting bloody material or things like that. All right, so let's get into some of the nerdy anatomy stuff here. So again, this should be relatively familiar. This is a diagram out of your books, and this gives you a very simplified version of the circulatory system. And so we see the heart in the middle, and we know that the heart is divided into two halves. You have a low pressure half that receives blood from the body and pushes it into the lungs to get rid of waste and collect oxygen. And then we have a high pressure side of the heart on that left that pushes the blood very forcefully out to the body, where that oxygen can be delivered to the cells and that the cells can drop off their waste products, right? And so it's really important that this closed system is constantly working, because the cells of your body are constantly demanding oxygen to make energy, and they're constantly producing waste product that needs to be gotten rid of. Now, obviously, the more your body is working, the more the metabolic demands go up. And so that's why when you start exercising, your heart rate goes up and your breathing rate goes up because you're making more waste, so you have to blow it off with your breathing, and your heart has to force out that oxygenated blood to meet the demand of the body. And this is just what happens. Your heart works harder when there's an increased metabolic demand in your body. So we can think of this in terms of the three components. So let me rewind here. There's three broad components here. There's the pump, the pipe, and the fluid. And the heart is the pump, right? So it's beating along, pumping blood out and being refilled by blood from the rest of the body. We have the pipes, which represent your arteries and veins, right? So you have the muscular, thick-walled arteries supplying the high-pressure oxygenated blood, and we have the thin-walled veins, which are returning blood to the heart. And so those are the container or the pipes. And then we have the fluid, which is the blood itself, right? And so that creates the pressure inside, which drives the oxygen through the walls of the capillaries into the tissues, right? So the pump, the pipes, and the fluid. So when we talk about the pump, the heart obviously is the human circulatory system's pump. And we have the four chambers, the two upper atria, and the two lower ventricles. The atria, the purpose of the atria is to give a little priming force to those ventricles. So the atria will squeeze first, drive that blood down into the ventricles to fill them up completely. And then the role of the ventricles is to squeeze forcefully. So these are much thicker, more muscular chambers, and they'll squeeze forcefully to drive the blood either on the right side up into the lungs, or on the left side out the aorta to the rest of the body, right? And so it's very important that the heart goes through this cycle of relaxing and filling with blood, and then squeezing forcefully and ejecting all that blood out. This is why during CPR, they tell you that you need to get full recoil, right? You need to come up off the chest to allow that heart to fill back up with blood. Because if the heart doesn't fill up with blood, what good is pressing down on the chest? If there's no blood in the heart, you're not going to pump anything anywhere. So you have to come up all the way and allow that heart to fill with blood. So that's an example of why that's working. So again, we have the right side, which pumps stuff out into the lungs. We have the left side, which pumps stuff out into the body. So now let's take a look at the pipes. So the human body has three main types of blood vessels. We have the arteries, which are, again, the thick-walled, muscular, high-pressure pipes that carry blood away from the heart. You have the capillary bed, which are the smallest blood vessels in the body, and these form a network that distributes blood to all parts of the body. So there aren't many cells in your body that are more than about 5 cells away from some sort of capillary blood vessel in order to give them the nutrients that they need to make energy and to offload those waste products. And then that all sort of empties out into the veins, which drain this deoxygenated blood away from the tissues and back up into the heart, where it can go through that cycle again. And so the last thing here is the fluid itself. And we talked a little bit about this, but the majority, the slim majority, a little bit more than half of blood, is plasma. And plasma is the liquid part of blood. So it's basically just water with a bunch of dissolved stuff in it to make it look slightly amber, right? So if you've ever put like a Band-Aid on a cut, and when you take the Band-Aid off, you see the little ring of yellow fluid soaked into the white part of the Band-Aid, that's plasma. That is the liquid part of your blood. Now, the scab, how it's like crusty and brown, it's that color because it's full of red blood cells, right? And so that's the other half of the blood. And then we have about 1% of your total blood volume, which is that little white band there. And that's where all of your white blood cells are. This is your platelets and the fibrin that make up blood clots and stuff like that. So they're really, really important, really sort of specialized and highly functional parts of your circulating blood. But really, the stuff that we are most interested in is the red stuff, right? These are these little Cheerio-shaped little biconcave discs filled with the protein that carries oxygen around. And that's really important because if we don't have enough oxygen, we go into shock. And so let's take a moment to just talk about what a pulse is, because I think this is relevant. So a pulse is the pressure wave in the blood that results from your left ventricle squeezing. So your left ventricle squeezes really hard. It sends a wave of blood out to your body, and we can feel that wave hit our fingertips when we press an artery against any hard surface, like a bone. So when you go down to your wrist and you press down on your radial artery, right? Whenever you feel that artery pressing up against your fingers, that corresponds to your left ventricle squeezing one time. And so that's what we get when we feel a pulse. So generally speaking, if you're conscious, you have enough of a heartbeat to feed your organs, and especially your brain, right? So you probably have a pretty good heartbeat, pretty effective heartbeat if you're conscious. And so you can easily find the pulse through your radial artery at your wrist. So on the thumb side, just in from the bone on your thumb side, you can feel that radial pulse. When we start to feel that pulse go away, that means mechanically in your chest or in the patient's chest, that means mechanically that heart isn't pumping as forcefully. Either it's slower or it's weaker, but something is happening that isn't pushing that blood out as effectively. And that's when we're going to start to see the patient going into shock. So again, what we do, if we can't feel it at a wrist, where else do you feel it? Anyone? Where do you go if you can't get it at the wrist?
Carotid or brachial.
All right, so someone said carotid and someone said brachial. Someone else tell me which one is correct and why.
Carotid pulse.
Okay, but why do we check the carotid versus the brachial in an adult patient?
Because it's easier to feel. You have to move the muscle in the arm to get to the pulse, so
right.
Push it against the bone, so it's in the neck.
Exactly. So we can feel the brachial pulse in an infant where they don't have a whole lot of muscle tone, right? There's not a whole lot between our fingers and that artery. But as we grow up and develop as humans, it gets a lot more difficult to sort of get in there and find that artery in the arm. And so, yeah, it's much easier to come up here to the neck and feel that carotid pulse sort of come in from the where the Adam's apple would be, where the larynx is, and sweep over to the side until you get to that groove between their windpipe and their sternocleidomastoid muscle, this sort of this big honking muscle that holds your head upright. That's where you're going to find your carotid. And so does anyone want to venture a guess why we would move from the wrist up to the neck if we can't feel it?
It's a direct passage.
You're asking why we want to go for the carotid pulse first, or if we can't feel a pulse in his wrist. What do you like?
Yeah, so if you check for a pulse at the wrist and you can't find it, what sense does it make to go up to the carotid?
Well, it's important because blood flow towards the brain that pretty much keeps the entire body active is important. So that's why you want to catch a carotid pulse.
Yeah, I think there's an element to truth to that. So the carotid pulse goes away last, right? The vessel is bigger. Like you said, it's feeding the brain, so there's a lot of blood flow that goes through it. It's closer to the heart than the wrist. So generally speaking, it's the last pulse that disappears before this patient goes pulseless. And so if you can't find it at the wrist, Well, we want to know if they have a pulse, right? Because being pulseless is very, very different than having a weak pulse. We go up to the neck and we feel it, and if we can feel it here but not down here, that's concerning, but they're not dead yet. So Andrew says, could someone have a stroke and cut off a radial pulse? So a stroke is something that blocks blood flow to the brain, whereas something that's blocking blood flow to the arm would not be considered a stroke. That would be like an embolus or something like that. So yeah, like a clot. And we see this sometimes in people's legs after surgery or after long plane flights, especially if they're at high risk for clotting. We can see these deep vein thromboses and stuff like that. Peripheral vessel disease and other sort of diseases like that. Yep. Okay. So let's talk about shock. So in medicine, we define shock as a failure to deliver oxygen to the tissue, right? So sometimes you'll hear this referred to as cardiovascular collapse, which is like a collapse of the system. Think like the collapse of a house of cards. Like the system is no longer functioning, not like the actual veins flatten out, although sometimes that happens too. But think of shock as a failure to deliver oxygen to the tissues where it needs to go. And this can happen for a lot of different reasons. So again, we're going to break it down into pump failure, pipe failure, and fluid loss, right? So again, failure of the heart, failure of the blood vessels to contain blood, and then some kind of failure of the fluid. In this case, if you have a pipe failure, like it breaks open, then the fluid is going to spill out, and that's definitely going to cause some issues. So pump failure is also known as cardiogenic shock. And cardiogenic shock, like the name implies, we have two words here, cardio, which refers to heart, and genic sounds like genesis. So genesis is the start of something. So something that is cardiogenic starts with the heart. And so a cardiogenic shock is a shock that is caused by something wrong with the heart. And so cardiogenic shock happens when the heart, for whatever reason, can't pump enough blood to supply the needs of the body. Pump failure can result if the heart has been weakened by a heart attack, for example, or other reasons. An inadequate pumping of the heart can cause blood to back up into the vessels of the lungs, and this will cause what we call congestive heart failure. So you'll hear people having CHF or congestive heart failure, and this is a weakening of one side or both sides of that heart that causes a backup of blood and an increase of pressure. So you can either see like their lungs filling with fluid or their extremities getting puffy, and this is a failure of the heart to sort of do its job. Pipe failure is caused by either the expansion of the pipes, right? So if you go from a 2-inch pipe to a 4-inch pipe and you don't increase the amount of water that's going through that pipe, then you've decreased the amount of pressure, right? And so if you've been through fire academy, then this will be familiar in terms of working with hoses. If you've done any sort of home renovation, you'll also sort of get this concept. But in effect, the container can get bigger or smaller depending on what your body's doing and what hormones are going through your body. And so the dilation of capillaries and to a lesser extent arteries and veins can really make a big difference in how much pressure is inside those pipes. So what can happen is the blood can pool in the capillaries instead of circulating through the system. And when this happens, not only is the rest of the body deprived of blood, but we can also see clotting disorders and stuff like that. But we also see blood pressure falls, and when you don't have enough pressure to drive that transfer of oxygen through the tissues, now your cells are starving of oxygen and start to die. So that's bad. And then we have, so I guess an example of this would be fainting, right? So has anyone ever stood up really fast and felt lightheaded? Is that sort of a common experience we've all shared, right?
Yeah.
And of course, what does that tell you? What's the first thing that goes through your mind when that happens?
Sit back down.
Yeah, sit back down. Yeah, Connor, exactly. Maybe we should drink a little bit more water, huh? Maybe we're a little bit fluid depleted. So what is happening there? Yes, William, exactly. So what happens is we stand up all of the sudden, and we don't have enough pressure to force that blood up into our brain, right? So our body goes from sort of this rest state to all of a sudden we sit up or stand up, and our body has to all of a sudden compensate for just the sudden onset of gravity, and so your heart beats a little faster, and it's trying to force your blood pressure up in that instant, but before it can sort of compensate, the blood drains from your head a little bit, and you get a little lightheaded and a little woozy. Now we can also see this in other circumstances. For example, one of the things that we will respond to is a condition called syncope, right? Spelled syncope. It's not syncope, it's syncope. And syncope is exactly what this says. It is fainting, right? So someone does something, either they're frightened, or they're trying to push out a hard stool on the toilet and they push too hard, or yep, that's a real thing. That is what we call a vasovagal syncopal episode. And so what that is effectively doing is it's putting you into a state of shock for just a couple seconds, enough to make you pass out, enough to make your brain stop functioning for a second, and you sort of lose all muscle tone, you flop over, fall to the ground, flop off the toilet or whatever, and then you wake back up once the blood pressure can be restored by your body's compensatory mechanism. It's compensating, right? And so this is known as fainting, but in medicine we call this a syncopal event, right? And like the slide says, this is usually self-correcting, either once they're placed in that horizontal position to allow their heart to pump more easily, or naturally as your body sort of ramps up its response. But in any case, we can look at this as a symptom of something else going on, right? With either the pump, the pipes, or the fluid. So another example of pipes not doing what they're supposed to be doing is, thank you, is anaphylactic shock. So does anyone know what anaphylactic shock is also known as?
An allergic reaction?
Yeah, exactly. Exactly. When someone says, I'm allergic to bees, and you ask them, okay, what happens when you take bees? And they say, well, I get really puffy and then I die. Chances are they're describing an anaphylactic reaction or going into anaphylactic shock. And so what anaphylactic shock is it's an extreme allergic reaction to some sort of foreign substance that develops very quickly following exposure, usually because they've been sensitized to it before. And what happens is, in addition to massive swelling that occurs all throughout your body, the blood vessels of your body become leaky, and they become leaky because they need to get all of this immune system stuff into the tissues in order for it to do, immune stuff to attack and kill and destroy and eat and digest and dispose of. Now, is there a need for that when you get attacked by a bee sting? Maybe where the bee stung you, but not throughout your entire body, which is why this is a bad thing, which is why we try to correct it with, EpiPens and stuff like that. But here is an example of where is that fluid coming from? When you swell up, where is that fluid coming from?
The heart.
Well, eventually all blood comes from the heart, right? But the fluid is coming from the blood. It's coming from your blood vessels, right? So your blood vessels are becoming leaky, and the stuff that floods into your tissues is the water component of your blood. It's that plasma, right? So if the water component of your blood is no longer in your blood, we're making the fluid less, right? We're taking fluid away from our blood and we're pushing it into our tissues. So not only is our airway swelling shut, not only are we getting hives and our faces swelling up and all of that, which is terrible, but also our blood pressure is dropping, which is also terrible. So Nick, this doesn't have to do with glands or lymph nodes or anything like that. This is the actual tissue itself that's swelling up. And so this is bad, right? So we're taking fluid away from our blood, we're dumping it into the tissues for really no good reason at all. And as a result, our blood pressure is going down, in addition to the fact that, we can't breathe and all that stuff. Just bad day all around. And so what do we do for this? Well, the answer is we give them a hormone that causes their blood vessels to tighten back up and causes the fluid to go back into their blood, and stuff like that. And it's a hormone called epinephrine. And we administer it in the form of an EpiPen or an epinephrine auto-injector. It doesn't have to be the EpiPen brand. That just happens to be the most common. And so we may talk about that. We may talk about that again later when it comes to bites and stings. But that's an example of a pipe failure. And then we have this thing called spinal shock. And this is also known as neurogenic shock. So again, here we have one of those Greek combination words, neuro, referring to nerves, and genic referring to it starts. And so neurogenic shock is a shock that is caused by something wrong with the nerves. And so in this case, if there's an injury to the spinal cord that causes swelling around the spinal cord or severs the spinal cord, what we see is the signal that goes from the brain to all of the blood vessels that tells them to be, exactly this much constricted or dilated, what we call tone, right? So if you imagine on a scale of 1 to 10, all of your blood vessels are at a 5, right? And if they need to be tighter, the body says, hey, you got to tighten up. I need you to be like an 8, right? Or if you're going the other way, hey, I need you to relax. I need you to be like a 4. Well, if you cut off all signals, your arteries and veins, they're lazy. They're going to be like, all right, I'm just going to be a 0. And they're just going to open up, right? And they're going to dilate completely. And all of a sudden you have this enormous container. The pipes are really big and your blood pressure goes down. And so this doesn't happen very often. But again, it's another example of a type of shock that is related to failure of the pipes. And what's really interesting about this sort of spinal shock is that you're above a certain level, your skin is going to look normal. It's going to look, well perfused. It's going to look pink, warm, and dry. And then below the level of the injury, all of a sudden everything is dilated and you're going to, the skin is going to look different there. And then you'll also see changes in vital signs. All right. Thank you, Morgan. All right, and then finally, let's talk about fluid loss. So fluid loss can be caused by any sort of excessive shed of fluid. So bleeding, which is known as hemorrhage, is the most common cause that we're concerned with, but you can also get it from diarrhea, excessive sweating, and other things like that. So blood escapes from the wounds if they come across any sort of blood blood can escape. So blood vessels including capillary beds, veins, and arteries, although obviously if you cut through an artery, it's going to bleed a little bit more because there's more pressure behind it. Veins are going to bleed a little bit less. And then if you manage to miss arteries and veins and you just cut into your capillary bed, you'll just see sort of a weeping of blood. But the more blood you lose, the less blood you have to deliver oxygen. And also the harder the heart and lungs have to work to keep up with what remains. So external bleeding is usually pretty easy to detect because, well, there's blood, right? And so this is why we do those thorough systematic blood sweeps, looking at our hands to find where that blood is. But with internal bleeding, the bleeding can't be seen from the outside, and you have to look for other signs of it. So bruising is a late sign of bleeding. You're usually not going to see a bruise immediately. It's usually going to take anywhere from hours to a day for bruising to show up from internal bleeding. Swelling, if something is swelling, then that's a pretty good sign that there's some sort of fluid collecting there. If you've ever gotten hit in the forehead and you've got a big old goose egg on your forehead, that's what we call a hematoma. Heme refers to blood, and toma is swelling, so that's a swelling full of blood. But also we can detect swelling when we press in on the abdomen. During our secondary survey, we're going to practice pressing in on the 4 quadrants using our fingertips. And if that feels harder than normal, or if we see the belly swelling up in sort of an abnormal manner, that could be evidence of massive internal bleeding. So again, rigidity in an area. And then severe pain can be one of those indicators of significant internal bleeding. But the fact remains, if you're losing blood out of your pipes, then you're going to go into shock. So whether it's external or internal, if it remains unchecked, the result will be shock and eventual pump failure. The average adult has about 12 pint glasses of blood as a sort of familiar measuring container. A pint glass, you have about 12 pints. In liters, this is around 6 liters in a normal sort of male, adult male. Women have slightly less blood volume than men do, and they have a slightly different blood composition than men do. And then, of course, the bigger you are, the more blood you have. The smaller you are, the less blood you have. So the loss of a liter of blood, 2 or more pints, can produce the beginning signs of shock, right? And so if you lose that first liter of blood, then you're going to start to see changes in your vital signs and things like that. And then the more blood you lose, the more the deeper that shock will become. So what are some things that can increase bleeding? Well, I have 5 things on the screen here. So when we move the patient, when the patient moves themselves, usually not too much cause for concern just yet because at least they're moving. But when we move the patient, we have the potential to physically disrupt any clots that have formed. So we need to be gentle with trauma patients in general. Low body temperature. So we don't discuss it in this course, but one of the first things I discuss with my EMTs is this lethal combination of cold patients and patients with poorly managed airways. And what happens is the colder you get, the thinner your blood gets. So you can get down to about 95 degrees, which is a hot day here in New Hampshire. But if your body temperature reaches 95 degrees, then you are actually incapable of forming clots. You will just continue to bleed and bleed and bleed and bleed, right? And so if we allow our patient to get cold, we will assist them in dying. And so one of the things that we need to do after we get this person, trauma naked, we've removed all of their clothing, we've found all of their wounds, we need to make sure the heater in the back of that ambulance is cranked and that we get this person covered in blankets and actively rewarmed if we can do that, because cold kills. And then we want to be very suspicious, especially in older folks, of medication that is meant to reduce clotting. So anyone with heart surgery, anyone with certain heart conditions, anyone who's had like implanted metal in their body, these people are going to be on drugs that causes their body not to create clots. You'll hear drug names like Coumadin and Warfarin, Eliquis, Xarelto. There's tons of these drugs out in the market. So if someone tells you or gives you a list of the drugs that they're taking, if this is a trauma patient, you need to ask them, are any of these drugs blood thinners? And hopefully they'll be able to tell you. In some cases, when we give fluids to trauma patients, and this is an advanced life support skill, so these are your advanced EMTs and paramedics, we are learning more and more about how the clear salt water that we carry around on the ambulance, what we call saline, is actually really terrible for trauma patients for a lot of reasons. And so that's one of the ways that we can, again, help someone in dying, is to give them a lot of those clear fluids. And then finally, removing dressings and bandages. If a bandage is working, then the worst thing you can do is peel it back and tear out the clot and uncover all of those bleeding vessels that you just put pressure on and wrapped up to investigate the wound or to check for bleeding. Listen, it's a bandage. If they're still bleeding, you're going to see red spots. All right. So once the dressing is in place, leave it in place unless there's some suspicion that it's not working correctly. All right, so we've been going for about an hour. Let's take a 10-minute break and come on back at 15 past 7, and we'll pick back up. And we can pick up with shock. All right, so signs and symptoms of shock. So we know that shock deprives the body of sufficient blood and therefore oxygen to function normally. And because of that, as shock progresses, we see some of the functions of the body start to be altered in an attempt to maintain that blood pressure and blood supply to the organs that really need it. And those organs are brain, lungs, heart, kidneys, guts, and what's that? Bernard, do you have a question? Nope. Okay. So maintain sufficient blood supply to those vital organs. So a patient who's in shock is going to exhibit some or all of the following signs and symptoms. And so we, as the brain starts to go away, we'll see confusion, agitation, restlessness, or anxiety. And again, that's because we're not perfusing the brain as much as we were. And then eventually we'll see signs of the body trying to take the blood away from places that don't need it and bring it back to places that do need it. And so your fingertips and your skin and stuff like that doesn't need blood supply for, immediately. Your skin and muscles and all of that can last hours without a sufficient blood supply and still be sort of kind of okay. Your brain can't do that, right? Your heart, your lungs, your kidneys, they can't do that. And so what we see is that your body starts clamping down all the blood vessels that are in your extremities and in your skin. And so what does that look like? Well, our skin gets cold. We see that a reaction to the hormones that are being released is that we start to sweat a little bit. And so the skin will be cold and clammy or moist. And then generally speaking, if you don't have blood underneath your skin, regardless of your natural skin tone, you are going to look less red, right? If you are very pale skinned like me, you're going to look ghostly white. If you are very dark skinned, then that will appear as like a grayish bluish color, right? If you have a very brown skin tone, so the two types of melanin, well, are brown, black, and none, right? So if you have very a predominantly black melanin in your skin, it'll appear as that kind of grayish color. If you have a predominantly brown kind of melanin, then it will also sort of appear pale and gray. Or if you're like me, it'll be white as a sheet, right? And that's because the blood is being taken away from the skin and brought into the center of the body. And then we discussed some of the other reasons for this. So why do you think that the rate of breathing will increase as you go into shock?
Because it's trying to pump more blood into those places. So the call for blood is going to make the heart pump more, and you're going to breathe more because of the CO and the oxygen exchange.
Yes, exactly. Yep, you're trying to get more oxygen onto that blood, right? Especially as you lose blood, every little red blood cell counts, right? We have to make them all count. And so we're going to breathe more and get more oxygen in there, right? And then, like you said, as metabolic demand increases, we're going to create more of that waste product and we have to get rid of it. And so the same reason that we see elevated heart rate, right? Your heart is working harder to pump around the remaining blood that it has, right? It's working as hard as it can to make the best out of limited resources. And so, all right, so we talked about capillary refill when we talked about vital signs. We know that it's when you squeeze any capillary bed, like a fingernail or an earlobe or something like that. Based on what we just talked about in the last slide, why do you think capillary refill time is going to increase?
Because blood flow is restricted to the capillaries in those areas?
Yes. Yes, you're absolutely right. And why?
Because your body is doing that to prevent blood from going to areas where it doesn't really need it and focus the blood flow to, your vital organs and brain.
Exactly, right? So all of this sort of makes intuitive sense because we know what's going on inside the body, right? Now, there is an organ system inside your body that is primarily focused on, our long-term survival, which is the digestive tract, right? We eat something now so that we have energy for hours, right? So in the immediate term, and we're talking seconds to minutes, your digestive tract really isn't as important as your heart, your lungs, your kidneys, right? Those things that are actively keeping your body alive from moment to moment. And so what we see is that when your body goes into this compensatory shock, right? When it's compensating for a lack of blood, we see that one of the first organ systems to get shut down is your digestive tract. And so what does your stomach want to do if it no longer likes or wants the food in it?
You throw up.
Yeah, exactly. So you're going to feel nauseous because this stuff is just sitting in your stomach and your stomach doesn't want anything to do with it. And in the worst case, you're going to vomit that stuff up. And that's usually a combination of a lack of blood flow to your GI system and all of the hormones that are coursing through your body as part of this this compensatory mechanism. And then eventually, if your shock is bad enough and fast enough, you'll lose consciousness. You'll slip into unconsciousness, you'll pass out, and you're on your way to death. If your shock is sort of a slow boil, right? Say you're losing blood over hours, or even as long as a day, depending on where you are. Your body's going to manifest the lack of fluid as thirst, right? And so people who are going into shock very slowly may state that they're thirsty. You may also get someone on your stretcher in the back of the ambulance and you're driving to the hospital and they'll tell you that they're thirsty. And again, this is their body manifesting that they don't have enough fluid in it, right? Now, are we going to give them something to drink? No, no, we're not. Because one of the things that they will need if they have traumatic injuries, the only solution to trauma in a lot of cases is surgery. And if we put something in their stomach, in addition to whatever they had in there, we already know that nausea and vomiting is a side effect of shock. If we put additional stuff in their stomach, it's not going to help the problem, and it's potentially going to make them vomit, which makes everything worse, right? Our job gets a whole lot more difficult when people vomit on us. So I think the big takeaways here, changes in mental status may be the first signs of shock. So we check level of responsiveness before we even start our primary survey. We want to keep checking and monitoring overall mental status, and that's going to help us detect changes in their vital signs, right? So if they were talking and all of a sudden they go silent on us, that's a sign of impending shock. Or maybe you're just so boring that they fell asleep. I don't know. Either way, keep them talking. So general treatment. To combat shock from any cause and to keep it from getting worse, we have to take the following steps. The first thing we're going to do is position the patient correctly. So if the patient has no head injury, extreme discomfort, or difficulty breathing, we want to lay this person flat on his or her back on a horizontal surface, right? Lay them down flat. You want to place a blanket under them and then also cover them up to try to keep them warm. We want to elevate the patient's legs according to local protocol. Does that do anything? Science says no. But still, try to make them as comfortable as you can. If the patient has any head injury, spine injury, lower extremity injury, don't elevate the legs, right? Don't move around an extremity that's broken. And if the patient's having any chest pain, difficulty breathing, if you don't think there's any spinal injury, then you can sit them up in a semi-reclining position or in a position of comfort. We want to maintain ABCs, right? So once we get their bleeding under control, if we don't maintain their airway open and adequate breathing, then not only are we not getting oxygen to the blood cells, the remaining blood cells that they have, but we're also building up those waste products inside their body, and we're increasing the amount of acidic carbon dioxide in their body. And we see that in addition to being cold, right, because remember that being cold makes it so you can't form clots, being full of acid also makes it so you can't form clots. And so if we don't do A and B, if we don't do those really, really effectively, we're actually making their trauma worse and making their bleeding worse. So it doesn't seem like it's all connected, but it very much is all connected. So we have to keep them as warm as possible, right? Even a little bit warmer than normal body temperature if we can manage it. And then we also have to keep them, their airway open, make sure that they're getting as much oxygen as we can deliver them, right? Through supplemental oxygen and excellent airway management. As always, if we can find the cause of the shock and we can treat it, then do that. If that means administering an EpiPen, if the patient has been prescribed one, then recognize the need and administer the EpiPen when it's appropriate. If it's because of bleeding, then we need to find the source of the bleeding and stop it, right? If we don't stop the source of the shock, they're going to keep on being in shock and eventually they're going to die from it. So we need to do that. And then again, don't let them put anything into their stomach that you don't want the surgeon and the anesthesiologist to have all over them once they get into the OR, please. Don't feed or water your trauma patients. And then you're going to be part of a healthcare team. Trauma, a lot like CPR, is a team sport. And so Bill mentioned at the very beginning, when do we call for ALS? Can we do that as soon as we recognize that it's one of these trauma emergencies? And the answer is absolutely yes. Get the cavalry on the way. Because while there's not a whole lot of specialized treatment that we can do that's going to help in trauma. There's a lot more knowledge and experience in these higher level providers that can certainly help us manage these patients. And so we want to make sure that we package these patients for transport as quickly and effectively and carefully as we can, and then get be an effective part of that healthcare team to give these patients an optimal chance of survival. All right, so questions about shock. Any questions about sort of the pathophysiology of shock, or what that looks like, or what we do for it? So let me ask you this. You're doing your patient assessment station, right? You're doing your skills exam, and you're going through airway, and you know that you assess the airway and you manage the airway. So you head tilt, chin lift, you insert an oropharyngeal airway. Bob's your uncle, right? Go on to B. We know we need to assess and we need to manage B. So we assess B, look, listen, and feel. We see that they're breathing at like 8 times a minute. We know that that's not adequate. And so we're going to get someone with a bag valve mask and start breathing for them. Fixed it. Bob's your uncle. We get to C. C is for circulation. We're checking for a pulse. They have a pulse. That's cool. We check for blood. We do a thorough blood sweep, right? We don't find any significant bleeding that we haven't already addressed. Fantastic. We check skin color, temperature, and condition. Color, pale. Temperature, cool. Condition, kind of clammy. That's not great. Seems like they're going into shock. Okay, we've successfully assessed C for circulation. What are we going to do to manage that? Are we going to start an IV? No. Right? That's not what we're going to do. Are we going to give any drugs to this patient? No, not really. What is the thing that we do when we manage C? As long as we don't find like sources of bleeding and stuff like that.
CPR.
What's that?
CPR.
So if we found a pulse, do we do CPR? Right? This patient is breathing.
Manage his temperature.
Say that again, Chris?
You want to manage the temperature.
Exactly. So when you're going through your skills station, remember, ABC, you have to assess and manage all of those, right? And so you're going to assess C, but then what are you going to do to manage it? And always have that in your mind. And in this case, all we got to do is keep them warm. So assess pulse, bleeding, skin color, temperature, and condition. You get 1 point for that. And then what are you going to do to manage it? I'm going to keep my patient warm. I'm going to cover him up with a blanket. I'm going to, turn on the heater in the back of the ambulance, turn it on high. Whatever you do, that gets you your extra point there, all right? So there's no reason to not get all of the points. You literally have the skill sheet. You're in possession of the answer key to this test. Just do all of the steps and you'll be fine, right? Easy day. So remember, ABC, when you get to C, how do you manage C? You're going to keep the patient warm. Excellent. Good talk. Okay, so let's move on. We're going to talk about pump failure. So treatment for shock caused by pump failure. This is obviously a pretty serious condition, and your proper treatment and prompt transport by ambulance to an appropriate medical facility will give these patients their best chance of survival. Because again, there's not a whole lot that we're going to do for these patients definitively out in the field. It doesn't matter if you're an EMR or a surgeon, right? If you're on the side of the highway, there's not much you're going to do for these patients besides what I'm teaching you to do in this course. So again, we go back to these sources of pipe failure. One of the ones that we talked about is anaphylactic shock. And once we recognize that they're going into anaphylactic shock, then obviously we need to recognize whether it's life-threatening yet or not, because just because they say that when they get stung by a bee, they go into anaphylactic shock. The fact that they are still speaking to you means that it is not yet time to administer that epinephrine autoinjector, because the epinephrine autoinjector is for when the patient starts to experience life-threatening signs and symptoms. If we give it too early, then what's going to happen is that they're going to take on the medicine, right? They're going to have all the effects of the medicine. It's not going to reverse anything because nothing is happening yet. And then it's going to wear off just in time for all these symptoms to come back in full swing. And then we've already used our epinephrine autoinjector. So don't do it too early, but do it once the signs and symptoms are such that they need it. So paramedics, nurses, physicians, they can administer medications that may reverse these allergic reactions, right? And will draw these medicines up in syringes and inject them. But patients who have already been diagnosed with severe allergies can and should carry epinephrine autoinjector packs, right? So generally they come in packs of 2. And the reason for that is not so you can throw one in the glove box of the car and one in the glove box of the truck. The reason why you carry 2 is because each one is only good for about 5 to 15 minutes worth of symptomatic relief, right? So the EpiPens that they give you are meant to buy you time until an ambulance arrives with more epinephrine. So don't leave one in the glove box to freeze during the winter so that it's no good for you when you need it. And certainly don't leave it in the glove box of your car and then go wander, 17 aisles deep into Walmart and get stung by a bee, where there's no chance that anyone is ever going to get back to your EpiPen in time for you to survive, right? Just don't do it. They're prescribed to you to carry on you at all times. And so when we find these severe symptoms, so the closing of the airway, the swelling of facial features to a great extent, to the point where they're unable to breathe, or to the point where they lose consciousness, where you can't feel a pulse anymore, in the wrist. These are all signs that this is getting really bad. At that point, you want to take out their EpiPen, right, and follow the directions. 3 simple directions. Take off the safety. There's a blue cap. You want to take the safety off. Hold it in your hand like a beer can. Don't put your thumb over the top, right? Hold it with the orange needle end facing someone else. Push that against their thigh. And we're going for, here's some medical terminology for you, anterolateral thigh, right? So not the direct side, not the direct top, but somewhere in the middle, sort of the meaty part of your thigh. Push it against their thigh and hold it in place for a few seconds, right? You'll hear anything from 3 seconds to 10 seconds. It all comes out very quickly, but we want to make sure it all gets into the muscle. So push it down till you hear a click and hold it in place for a few seconds, and then you've successfully administered the auto-injector, right? And in case you ever forget these steps, they are printed on the auto-injector itself. It'll say 1, remove safety, 2, press against thigh, 3, hold in place.
They even give you a practice one too.
Oh, they sure do. They sure do. So Reagan asks a great question. What happens if this is their first time dying of anaphylaxis? And the answer is, well, fortunately, the very first time generally isn't the most severe time, because they're generally sensitized the first time. Now, that's not always the case. And if they're going into anaphylactic shock, you need to get 911 there as soon as possible. You need to get someone there with a sufficient level of medical training that they can draw up epinephrine and give it to this patient. And so in the state of New Hampshire, we train EMTs to draw up epinephrine and inject it, right? So if you have an EMT on scene with you, they can give their own epinephrine. Otherwise, if it's just you as a sole EMR, you need to get help on the way, because there's really nothing you can do at that point. So Nick asks, by law, are we allowed to administer? You are allowed to assist in administration of someone with a prescription. So you cannot carry around your own EpiPen and give it to someone else. You can't take someone's EpiPen on scene and give it to your patient. Your patient has to have their own EpiPen, and then you can assist in administration of that EpiPen. The only people who can administer epinephrine, from a medical standpoint, the only people who can carry their epinephrine and administer it to a patient is EMT and above in the state of New Hampshire. So Daniel says he's seen videos of people messing with EpiPens and triggering them. Yeah, it's pretty easy. It doesn't take a whole lot of force to get these things to go off. Once you pull the safety mechanism off, they're ready to go. And the spring that pushes that plunger is actually a really powerful spring. When I demonstrate EpiPens to my EMT classes, I usually use a cedar shingle, and it will go right through the center of that cedar shingle. So it makes it through a credit card. It'll make it through a thin wallet. You always want to check the patient's clothing and pockets to make sure that the needle is not going through anything. You want to give it the best chance of success. But it's a really powerful needle, and so it will absolutely go into your thumb if you don't beer can grip it. So remember, we need to hold it like we're holding a baseball bat. We don't want to put our thumb up over the top of it, because if we put our thumb up over the bright safety orange end, the bright end with the universal color for don't touch this one, if we touch it, then there'll be a needle that goes through our thumb and it'll squirt epinephrine everywhere. It'll be very uncomfortable. Bill says, for best results, 10 seconds. Absolutely. So I've heard anywhere from 3 to 10 seconds. It depends on the manufacturer. I can tell you that the epinephrine comes out in less than a second. But again, for best results, you want to hold it there for several seconds, whatever the manufacturer specifies in the instructions. And it does vary by equipment. If someone goes into anaphylactic shock and it will be more than 15 minutes and they don't have an EpiPen, are they out of luck? Yes, they are. And so you will do all of the other skills that you can to stabilize and treat this patient until someone can arrive with the resources that you need. So if you respond with an ambulance and an EMT, then no problems, because you arrive with the resources you need. If you respond with your personal vehicle and your first aid kit, then you're not going to have the supplies you need to effectively manage someone going into anaphylactic shock, and you have to do all of the other things that we teach you to do for shock, which is position the patient, ensure that their airway is as open as possible. If you have oxygen, administer it. You want to keep them warm, and just make sure that dispatch knows that you need preferably an ALS truck, if not any sort of EMT. So Catherine says, what I'm saying is that she should really carry her EpiPen with you. Yes, and not just one, but both of them, because you got them in a pack of 2. And if you'll notice, it has temperature limits on them. So if you leave it out in your car and let it freeze during the winter and cook during the summer, when you need it, the epinephrine inside will have degraded a little bit. We've actually run studies. It doesn't degrade that much, but still, do you really want to gamble? Yeah, I know you did. Everyone does. Okay. All right, so moving on here. Talking about fluid loss. So shock caused by internal fluid loss. It's important to recognize this by signs and symptoms, because we're not going to recognize it any other way. If you're treating several injured patients, the people with internal bleeding should be transported first, because they may need more emergent surgery. Sources of bleeding internally can come from stomach ulcers, ruptured blood vessels, and other sorts of diseases. These can all cause internal bleeding. It can be spontaneous. It can be massive amounts of bleeding. And it can lead to obvious rapid onset of shock. So in addition to the classic signs of shock, people with internal bleeding may show other signs, like They may cough up blood. They may vomit blood, especially if they have those stomach ulcers or if they have ruptured blood vessels in their esophagus. We see this a lot with like chronic alcohol abuse. They may have abdominal tenderness, rigidity, bruising, or distension if they have bleeding inside their abdominal cavity. They may report that they have bloody stools, or they may have just frank bleeding from their rectum. This is a sign of lower GI bleeding, right? So bleeding that is within the intestines. And then vaginal bleeding, especially if this is a postpartum woman or a woman who has just given birth. There's a large organ that they grow inside their uterus that is connected to blood supply, and that gets sort of peeled away at the end of childbirth and leaves a lot of blood vessels exposed. And so if the muscles relax, then this can lead to bleeding again, and that bleeding can be significant enough where they'll go into shock. And so we'll talk more about that when we hit on OB/GYN and childbirth later on in the course. But all of these can be sources of significant bleeding. And so how do we tell the difference between bleeding that is obnoxious, bleeding that we're going to find and correct during our secondary survey with, bandages and stuff like that, and life-threatening bleeding, like bleeding that we are going to fix before we even open an airway or check for breathing? And the answer is right here on the screen. This graphic comes from the American College of Surgeons Committee on Trauma Stop the Bleed program. And so their recommendation is that if you see blood spurting out of a wound, right, that's a sign that it is arterial in nature. And it sort of gushes out and spills out when you lacerate these large arteries. It's like someone has a hose and they're just sort of crimping it and uncrimping it. The water sort of gushes out. And that's obviously terrible, and we need to correct that. If you do bleeding control interventions and direct pressure and all of these other bleeding control measures don't work, if someone is like pressing their hand over the bleeding site and blood is just spilling out, that's terrible and needs to be fixed immediately. If they've used bandages or towels or anything else to stop the bleeding, and these towels are just entirely drenched in blood, that's terrible. If you come up and they're missing part of their body and blood is coming out of what remains, that's terrible. That's called an amputation. We'll talk about that later. If you come up on someone and there's a large pool of blood on the ground, not always going to be an indicator of significant bleeding. So right now there's a lot of snow on the ground. If you bleed into snow, the blood goes straight down until it hits a hard surface that it can't melt. And so this person could have lost a lot of blood and you won't see it. But if you come up on someone and you see a lot of blood, that should sort of trigger your spidey sense that this person has life-threatening bleeding. If you see that their clothing is soaked, or again, wintertime in New England, if you see that their waterproof clothing has pools of blood in it, like what we find on ski patrol, everyone's wearing waterproof clothing when they go skiing. When you have someone break themselves open on the inside of their skiing suit, we see that you have like these large water balloons of blood on the inside. So that's obviously terrible and needs to be treated immediately. And then anytime you see bleeding in conjunction with someone with an altered level of consciousness, right? So again, the three things that we check before we launch into our primary survey: general impression, level of consciousness, and presence of life threats. If we see a decreased level of consciousness and they're bleeding, we have to assume that the reason they're unconscious is because they're bleeding, because that is the worst case scenario. That is the emergency. And so we fix that first, and then we move on. And so Christopher says your ambulance and first in bag should have a tourniquet. Absolutely. In fact, it is a requirement to be a state licensed ambulance. You have to have a tourniquet, and we're going to talk about that in just a little bit. So controlling bleeding. So the least the least dangerous and most common type of bleeding, right? So least dangerous, most common. This is the kind of bleeding you'll see the most in your career and in your life is capillary bleeding, right? This is cutting open, just the soft tissue of your body, not getting into any of the big blood vessels. This is, blood oozes out. It hurts a lot because you slice open nerves, but generally direct pressure and then some kind of bandage will be just fine to control capillary bleeding. It'll form a clot. It'll be fine. The next worse or the next more serious type of bleeding, but again, not always life-threatening, is venous bleeding, right? And venous bleeding, it doesn't have that direct connection to the pumping side of the heart. And so it's not going to be pulsatile in nature, not always. It's generally going to be darker in color. It's generally going to be a steady oozing flow. And this requires a little bit more vigorous bleeding control. So you're going to want to apply direct firm pressure over the bleeding site. You're going to be hanging out there for about 5 minutes. So this is a great time for you to, get a non-medically trained firefighter to come over and have them hold firm direct pressure, or in the worst case, get a bystander to hold firm direct pressure while you continue your assessment. But they're going to need to hold direct pressure very firm for at least 5 minutes to get this stuff to clot up and stop bleeding. This is a great candidate for a pressure dressing. And then the most serious type of bleeding is arterial bleeding. So again, arteries directly, they're the vessels that take blood away from the heart directly. And so every time your left ventricle squeezes, you're going to have a pressure wave of blood hit that open artery. And so you're going to see it either spurt out if they have enough blood pressure, or as their blood pressure dips, you're going to see it start gushing out, right? And so this is going to be usually bright brick red, like fire engine red. And you're going to need to put direct pressure over this. And in some cases, the larger arteries will need a tourniquet in order to control blood flow. And so we're going to teach you more about that right now. All right, so there's generally 3 places on your body that we think of when we think of bleeding control interventions. The limbs, the junctions, and then your chest and abdomen, right, sort of grouped together where your guts are. And so your limbs are the places of your body that are amenable to a tourniquet, right? They're something that we can wrap a band around, and we can tighten that band until it squishes the artery shut, and then we've cut off blood flow, right? It's like turning the water off to your house at the water main. If there's no water going to your house, you can't have leaky pipes. Wrinkly brain. Now, obviously, if we put a tourniquet around someone's waist, first, usually not going to fit. Second, not going to do anything. And definitely never put a tourniquet around someone's neck, no matter how much you want to, right? Tourniquets are for arms and legs only. But there are places that can get injured that have big vessels in them that are not amenable to a tourniquet. We can't get a tourniquet around it, or if we do manage to get a tourniquet around it, it won't be effective. And these places are called the junctions. This is going to be up in the pocket of your shoulder, up along the side of your neck, in your groin, sort of below the below the level of the abdomen, but above the area where you can normally get a tourniquet. This is including like the meat of the gluteus muscle, what we would call the butt cheek. It's not yet up in the organs of the abdomen, but you're not going to get a tourniquet around it. It's not going to be effective. But if you get a big gaping hole in it, like a gunshot wound or an explosion or something like that, you're going to need to get in there and control bleeding. So these are what we call the junctions. And then finally, we have everything else, this chest and abdomen. And we don't have an intervention in the field for this. There's nothing that we are going to do in an ambulance, on the side of the road, in the woods, on a mountain, in a helicopter, in the desert, underwater. There's nothing that we're going to do to fix this in the field, especially at the paramedic and below level. Nothing that we can do. This needs to be fixed with surgery. And so for the junctions, so taking it back to the junctions, for the junctions, we can pack wounds, right? So every ambulance in the state of New Hampshire should have some kind of hemostatic blood clot enabling gauze. And if you don't have that, regular gauze will work. And what we want to try to do is fill these wounds with gauze, packing them shut, and holding pressure on those bleeding vessels internally, and then putting direct pressure and bandaging and all that. For the chest and abdomen, again, there's nothing that we can do except keep the blood inside their body. We can make external bleeding become internal bleeding. That's really the best we can do for these folks. And so what we use for this is what's called occlusive dressings, and we'll talk more about those when we get to chest injuries, but they're basically watertight stickers that we can apply over any holes that will basically keep the blood inside the body. If they're going to bleed out, they're going to bleed out. And if they're going to stabilize, we're going to give them the best chance to stabilize by keeping the blood inside their body. Now, I inevitably get the question, why can't we pack wounds to the chest and the abdomen? Why can't we fill these with gauze? Does anyone want to use their knowledge of anatomy and physiology to venture a guess as to why packing the chest or abdomen would be a bad idea?
Because of air, they might not be able to breathe well. I don't know. It's just a guess.
That's an excellent guess. So if they have a gunshot wound or like a
You don't want to
hunting
dry
arrow,
up the area.
if they have like a hole in their chest for some reason, and we pack it full of gauze, then their lungs can no longer expand. Not only are we not doing what we think we're doing, because the major bleeding artery is either the heart itself or the aorta, right? And the aorta is attached to the spine, so we'd have to literally fill their chest with gauze. And let me tell you, there isn't enough gauze on a single ambulance to do that. But also, if we're successfully packing this, their heart won't be able to move and their lungs won't be able to expand, and we will kill them. So universally a bad idea. So may interrupt organ movement. Definitely not, clogging the area, not allowing the lungs to expand, not allowing the heart to move. Exactly. It's physically impossible because you'd have to get like 7 ambulances worth of gauze to fill up that area. But also just doesn't do what we think it does. And the same with the abdomen. Like, we have organs there, and the major vessel that would be bleeding would either be directly attached to one of those organs or would be the aorta attached to your spine, and you're just not going to fill that area with enough gauze to create enough pressure to clamp down on those arteries without destroying all of their organs. So that's why this area, the chest and the abdomen, just gets a sticker over it. It just gets an occlusive dressing, some kind of seal to keep the blood in, because nothing that we have in our ambulance, nothing that we are going to do in the field will fix what they have wrong with them. And the best thing we can do is to do what I do when the cat poops on the rug, which is cover it up and let someone else deal with it. And in this case, we're going to cover it up and we're going to let the trauma surgeon deal with it. All right, good talk. So again, let's talk about bleeding control intervention. And this is going to be a skill that you're going to be asked to demonstrate on the state BLS exam, right? So it's going to be on your final exam, it's going to be on your state exam. So the first intervention for any bleeding, doesn't matter what it is or where it is, your first intervention is direct pressure. And the first thing you're going to place direct pressure with is a hand, right? Does it always have to be your hand? No. Can it be the patient's hand? Usually no, because patients don't hold enough pressure on their own wounds generally to fix things. Because holding direct pressure over a significant bleed is a little bit painful. So I wouldn't count on the patient holding pressure on their own wound, but if you can get a bystander, another first responder to hold pressure on this while you get your equipment together, that would be great. So again, initial bleeding control, no matter what it is, always starts with direct pressure. If you see they have an amputation and you know you need to apply a tourniquet, someone better be holding direct pressure while you fish through your bag and get that tourniquet out. All right? So ideally, we want to place a dry sterile dressing directly over the wound, press down with a gloved hand. Again, for capillary bleeding, which is the most common type of bleeding, this is going to be all you need. Hold that down for 30 seconds to a couple minutes, and again, Bob's your uncle. You've controlled bleeding. You're a healthcare hero. If that doesn't work, you're going to have to upgrade this to something more aggressive. And so this talks briefly about elevation. So elevation does not stop bleeding, right? You can hold your hand above your head. I challenge you to do this. If you hold your hand above your head, your fingertips are not going into shock, right? The heart is actually very capable of pumping blood to your fingertips. So elevating your extremities are not going to control shock. But what it does do is it allows you to get in and assess the extremity. So you should be elevating extremities as you assess them for bleeding, especially looking up in the axilla where bleeding wounds can hide. And I want to go back to this. So we have direct pressure with a dressing, but we also have something called a pressure dressing. And so what a pressure dressing is, if you find that this is not sufficient, you can put a wad of material over the top of that and press down directly on that, right? And then bandage that down. And that focuses the pressure of the dressing over the bleeding area. So dressing, pressure dressing, and then bandage around that. That's sort of your escalating approach to your capillary and your venous bleeding, and sometimes your arterial bleeding. So Nick asks, amputation, where would you hold? At the source of the bleeding. Wherever the blood is coming from, put your hands over it and press down hard. All right, so tourniquets. The use of a tourniquet is indicated in situations where extremity bleeding cannot be controlled by direct pressure, or when your initial impression of the bleeding is that it cannot be controlled by direct pressure, right? So again, if we come up on someone and we see spurting bleeding, if we see pools of blood or soaked bandages or clothing, right? These are signs of life-threatening bleeding. And we would be well within the realm of what is acceptable if we skip right to a tourniquet, right? Because it's far better to be overly aggressive when it comes to bleeding control than being timid in your approach and allowing them to bleed out and go into shock and then deliver a patient that is less likely to survive. If you put a tourniquet on, it can always be taken off later and there'll be no worse for wear, generally speaking, right? But if you don't apply a tourniquet, they could bleed out while you're trying to figure out what's going on. Morgan, you raised your hand.
So just to clarify, because doing the military training, they always told you, I mean, you would put the tourniquet on, but if you were putting the tourniquet on, to be aware that the person would probably lose the limb. So has that pretty much kind of gone down the wayside now?
That's a total myth. There's no case evidence to support it. Well, okay, anything can be harmful if you do it wrong enough. So there's been a couple cases where people have put on tourniquets incorrectly, and it has led to damage to the limb that can be sort of directly traced back to the tourniquet. But if you do this skill correctly, and I will teach you how to do it correctly, at least the Walpole crew, if you do this skill correctly, your leg is not going to turn black and fall off like an umbilical cord. It just doesn't happen. We've been using tourniquets since like the 700s, and we use them relatively extensely in World War II. Sort of lost our way in Vietnam, and a lot of people died because of it. And then they came back at the start of the global war on terror. There's just no evidence to support that, and we've applied thousands of tourniquets. And so there is a time limit. This is not a completely benign procedure. You can certainly cause damage, especially if you do the skill incorrectly. But if the tourniquet stays on for 2 hours, 4 hours, 6 hours, way longer than any sort of ambulance transport within the state of New Hampshire. But if this tourniquet is on for a long enough period of time, then we're not actually concerned about damage to the limb as much as we are when we take that tourniquet off. All of the waste product that's built up inside the limb is going to rush up and affect your heart. And so when we take tourniquets off these people, we generally have them on heart monitors, and we have a bunch of heart drugs ready and stuff like that. So the problems that we encounter with tourniquets are not even the same problems that people think are what you would encounter, or what myth has been sort of propagating over across history. So
Perfect. Thank you.
yeah, absolutely. It's a great question. And we're going to address some of the other myths as well. So high velocity gunshot wounds, explosive devices, chainsaws, industrial machinery. The last amputation I personally attended to was right here in Manchester. And it was someone who had a 2-martini lunch and then got run over by a forklift. And if you've ever seen a forklift, they have like a 3-inch draft. There's not a whole lot of room under there. So it sort of like squished his leg into. And part of that was severing his femoral artery. And so that guy got a tourniquet. He actually got 2 tourniquets because he needed 2 tourniquets to apply enough pressure to squeeze down on that femoral artery. And so lots of ways that you may encounter the need for this. So you can apply a tourniquet. It can be left in place for several hours without causing significant damage to the limb. Use tourniquets if you should have proper instruction and be practiced in their use, and have protocols in place that have been approved by your medical director. So in the state of New Hampshire, this is a universal skill. Police officers carry tourniquets, right? This is a bystander bleeding intervention. But make sure that you get your hands on these tourniquets when we practice them in class on Saturday. So here is the procedure. First thing we're going to do is we're going to get this around the affected extremity. So generally speaking, if you don't know where the bleeding is coming from, you're going to place the tourniquet as high as you can on the affected extremity, right? So on a leg, this is going to go all the way up towards your waistline, right? As high up as you can get it. Again, not over the hip because it's not going to work like that, but as high up on the leg as you can get it. And if it's on an arm, you want it as close to the shoulder without going over the shoulder because, again, it's not going to work, but as high up on the arm as you can get it, all the way up in the armpit. If you can't see the source of the bleeding, you need to shut the blood off at the highest level. And then doesn't matter where the bleeding was, you've controlled it. If you can see the source of the bleeding immediately, then place it 2 to 3 inches above the maximum extent of the wound. When in doubt, go high, right? If you have any doubt in your mind, just go as high as possible. It isn't going to hurt the patient in the long term. So put it around the affected extremity, weave it through whatever fastening system that the tourniquets you use have. In this case, this is the combat application tourniquet. It is very, very popular. One of the many approved tourniquets, but there are others on the market that will work just fine. And then you want to get this as tight at a buckle as you possibly can. You want to tighten this thing down like you're securing furniture in the back of the pickup truck and you're about to cruise down the highway. All right? You want to get this thing tight before you ever start turning a windlass or using a ratchet or whatever you have to tighten this thing up. Once you get it around the limb, then you're going to use whatever tightening mechanism that you have. So there are ratcheting mechanisms and there are windlass mechanisms. Generally speaking, anything with an elastic in it is not something that has been approved by the committees and agencies that approve these sorts of things, mostly the Department of Defense, because it just either hasn't been tested under the sorts of conditions that we encounter in EMS, outside, in the rain, people covered in blood, in the dark, on the side of the road. They've only been tested in like well-lit laboratories with people with their legs elevated a perfect ideal situation. So again, when you're making the decision of what to purchase for your kits, or if you have any say over what your agency purchases, make sure you go for something that has a fair bit of science and evidence behind it. So you're going to activate whatever this mechanism is. In this case, it's a windlass rod, and you're going to twist this in order to produce the amount of pressure needed to compress that artery inside the body. And then you're going to secure it. And then in this case, you see that the securing strap itself has the word time written on it. It is a good idea, if you can remember, to write the time of application, because again, if we get into the 4-hour, the 6-hour mark before we take this thing off, at the hospital, they have a bunch of additional considerations for how to take that off the patient, right? They're going to hook them up to a heart monitor and give them drugs and all that stuff. So again, this illustration over here sort of demonstrates this person has some kind of massive wound to their leg, right? You can see all of the arteries feeding the leg on the other side that are intact. And on this side, we put on the tourniquet, and if it's tight enough, it's going to shut off blood flow to the rest of that extremity. And if there's no blood going down to it, it can't bleed. So some mistakes that we see. Waiting too long to put on a tourniquet, right? So you go direct pressure, and then you put a piece of gauze on it, and then you upgrade to a pressure dressing, and that soaks with blood, and you're like, should I put on a tourniquet? My best friend's uncle's cousin's aunt said that their leg would turn black and fall off if I did that. Maybe I should just let this person bleed out instead. You're behind the power curve there. So if you think you need a tourniquet, put it on. Second big mistake, not pulling enough slack out, right? So again, you need to tighten this thing down at the buckle like you're preventing a couch from falling off the back of a truck going down the highway. It needs to be tight. If it's not tight, then you're gonna twist that windlass, and you're gonna twist and twist and twist and twist. And trust me, if you can get more than 2 or 3 twists on that without the patient yelling in pain and the plastic of this thing starting to creak and strain with stress, it wasn't tight enough. And we're gonna demonstrate that this weekend. On the other end of things, if you put a tourniquet on someone with, a minor laceration, you're going to catch some guff from that once you get into the emergency department. They're going to tell you, "Hey, listen, I appreciate your enthusiasm, but for future reference, this didn't need a tourniquet." But again, I'd rather be told that about a patient who is living than told later on about a patient who's dead that I should have applied a tourniquet, and now it's my fault that this person's dead. And then there's some other things. If you can see the bleeding and you put it on too high, again, that's sort of points off for style. Loosening the tourniquet, we don't do that. That was something that was suggested back in the Civil War, and it's no longer the 1860s, so we can't get away with bloodletting, right? Bloodletting fell out of favor back in the 1700s. We don't do bloodletting anymore, right? So don't loosen your tourniquets. And then lastly, don't put a tourniquet over a joint. Not only does it hurt and is disruptive to the joint, but it just doesn't work. You have bones there protecting the arteries. It's not going to work. So don't put it over the joint. And then over here in the corner here, you see some rope or shoelace with a big no symbol over it. Tourniquets need to be wide. They need to be wide, and they need to have some kind of mechanical advantage. If you try to use rope or string or something like that, you're going to cut into the skin. You're going to damage the skin. You're going to damage the underlying nerves, and you're not going to put enough pressure over that artery to stop the blood flow. And the same with like if you try to use a belt. If you put the belt around the extremity and you pull up as hard as you can, there's no mechanical advantage there. Right? You're not going to produce any more force than you're able to just sort of pull and hold with your own arm, which isn't a lot. And you're not going to compress those arteries enough to stop the blood flow. And so you need some kind of windlass or some kind of ratchet or some kind of other mechanical advantage to really get the pressure that you need. All right. All right. So what I'm going to do is let's put you on a break now. Since I've talked way over our time limit, come on back at 8:30 and we'll continue to power through these slides. We're about halfway through now. So take 10 and come on back 8:30. All right, so let's continue on with standard precautions, and we'll move forward through the rest of this stuff. So some communicable diseases can be spread by contact with blood from an infected person. To minimize the risk of this, we wear nitrile gloves. We generally don't wear latex gloves anymore. There's not a whole lot of latex gloves to be found in medicine. They do still exist in some applications, but most of the gloves you'll find are nitrile, which is a non-allergenic substance. And so don gloves before playing with anything that's warm, wet, or squishy. If you do get blood on your hands, all you have to do is wash it off with soap and water. If you can't wash your hands, then use some sort of waterless hand cleaning solution. Usually these contain alcohol, either isopropyl or ethanol, and that will kill a lot of the germs and pathogens. But fundamentally, if you don't have a break in your skin, then there's no entrance for anything to get inside your body, right? So if you have a wound and you get blood from their wounds into your wound, then there's a chance for that to spread. But generally speaking, there's no need to panic if you get blood on your intact skin. That said, if you get someone else's blood in your eyes, in your nose and mouth, in a wound, or if you get stabbed by a needle or anything like that, then that is considered an exposure, and you have to report that either to your own EMS agency or report it to the hospital. And depending on what the patient has, you may have to do some post-exposure prophylaxis and other sorts of things. All right, so let's get into wounds and wound care. So a wound is any injury caused by physical means that leads to physical damage to a body part, right? And so we classify wounds as either being open or closed. So a closed wound, as you would imagine, the skin remains intact. So the only evidence of a closed wound is perhaps a bruise or a deformation of the area of the body, but with no break in the skin or external bleeding. So generally what we see is, for example, bruises. These are where small blood vessels within the tissue are broken open and blood starts to collect in the tissue. And so you can imagine blood being the color that it is, that initially you'll get a redness and a swelling. And then as the blood clots and then gets decomposed by the body, it will turn from red to purple to blue, and then you'll see it sort of turn maybe green or yellow, and it'll eventually fade away. A simple bruise heals quickly, but depending on the size of your bruise and the amount of blood in your tissues, your body sort of needs to work through all of that junk and digest it as best it can. So bruises and swelling may be signs of underlying conditions like fractures or other sort of ruptured stuff. And this is in contrast to open wounds. So if there's a break in the skin, all of a sudden it's an open wound. And there's lots of different open wounds. So we'll start with an abrasion. An abrasion is basically where there's some sort of friction and the skin gets rubbed off, right? So this can be a scrape, a rash, rug burn. All of these are examples of abrasions. So here's a sort of a picture of an abrasion and a cross section of the skin. We can see that it's only the outermost layers that we're sort of flirting with the beginnings of the capillary bed. So these may weep blood, so you may see blood tinged fluid, but in a lot of cases these will weep that yellowish fluid, and that is the plasma, right? The liquid component of the blood, what we call serous fluid. The treatment for abrasions, generally speaking, is we want to clean them. So we generally have water or sterile water, sterile saline We can sort of irrigate out, you know, dirt and other things that are in the wound. This wound will get significantly cleansed when they get to the emergency department, but do what you can to just clean it up a little bit before you put a bandage over it. And then basic bleeding control, you know, a non-stick pad with some tape should be sufficient. You don't really have to do a big patch job on these things if they're not bleeding significantly. Next, we have a puncture, and this occurs when any sharp object penetrates the skin. Generally, punctures are deeper than they are wide or long, right? They go into the skin deeper. And so this may cause significant deep injury that is not immediately recognized, right? So there may be more damage inside than out. These may not bleed freely unless you like nick an artery on the inside. If the object that caused the puncture wound is still sticking out of the person, we refer to this as an impaled object. And impaled objects are not removed. We don't pull anything out of a body. Can anyone tell me why it would be a bad idea if there's a stick sticking out of someone? Why it would be a bad idea to pull that out?
Because
You could hurt
create
the
more-
internal organs and cut arteries, cause more extra damage to your patient.
All right. What do other people think?
You can initially cause more damage than good.
Yes. Yes, you can. So when we talk about breaking arteries and causing damage to the inside, that's already done, right? The object already penetrated the body. It's already disrupted whatever internal anatomy has been disrupted, right? But if we pull it out, then
bleed out.
we cause the chance, whatever that object was holding pressure against, right? Because effectively it's its own wound packing at this point. It perfectly fits the hole it created. If we pull that out, now any blood vessels that were disrupted can bleed and fill up that hole, right? And so a bunch of people were talking about bleeding. Yes, you give the opportunity to destabilize that injury, to break up any clots, and to cause their wound to start bleeding heavily in a way that's difficult for you to treat, right? Because this wound is very small and goes very deep. So it's going to be difficult for us to treat that. And so because of that, in the field environment, we immobilize these impaled objects, right? And so we will talk a little bit about that, or we'll do this skill, not this weekend, but next weekend. We will hit on those skills. And so here is an example of an impaled object, right? So we see that I'm not even sure how this happened. It looks like maybe it was fired out of a nail gun. So never disable the safety on your nail gun with your fingers, I guess, is the life lesson here. But, take of it what you will. This person needs to have this removed, and we are not going to do it in the field. Fortunately, this thing here is probably pretty easily immobilized by just telling him not to move his hand around too much. But something more significant would need padding around it and would need to sort of make sure that the object doesn't wobble around and cause more internal damage. All right, so Dustin asks, what if it is through and through? Can you cut and to shorten it and make it easier to move the patient? Yes. So, like, if they were impaled by a stop sign that is, like, attached to the pavement, you're going to need to trim this up in order to move them to the hospital. The only alternative is to move the hospital to them. And I would say that between the road sign attached to the road and the hospital, both of those are pretty immovable. So yes, you would get the fire department out there. They have cutting apparatus. You're going to protect the patient from any sparks or other debris. You're going to try to stabilize the patient as best you can while this is trimmed, and then you're going to take that patient to the hospital. Nick, I have no idea what you mean by I had a patient do that for opioid usage, but that sounds like a fascinating story, and I'm going to ask you about that once class is over. All right, lacerations. So lacerations are a lot of the wounds that you're going to see are some kind of laceration. This is basically just a cut. It's a wound that is longer than it is deep, and a lot of times these are minor, right? If you cut through tissue that doesn't have a large number of big veins or arteries, you could actually have what looks like a pretty good laceration with big flaps of skin, and it won't really be bleeding that much, right? You'll get a lot of capillary bleeding, but you won't get any major arterial or venous bleeding. It really depends on where the laceration is on the body. So just because you see a major laceration doesn't mean you need to jump to a tourniquet or wound packing. Look for the signs of life-threatening bleeding, but then address the signs that you see, not necessarily how you feel about how big the injury is. That said, large lacerations can cause excessive bleeding and be potentially life-threatening. So take a moment to evaluate what you see there. Right? So here we see an example of a laceration. This looks to be across the knee. So here's a kneecap. Up here, I assume, is the thigh, and down here is the lower leg. And so we see this big laceration going across the front of the knee. Now, I know from anatomy and physiology that the major blood vessels that travel through this joint are actually on the back side of the leg. And so it's probable that he has not injured any major blood vessels with this pretty nasty looking scrape. And so a lot of this blood, as you can see, it's not actively bleeding now, so it's probably formed clots. We see down here that bleeding was controlled. It looks like a bunch of 4x4 gauze pads, right? So we didn't use a whole lot of material to control this bleeding. So this is a great example of something that looks pretty nasty, but can actually be controlled through relatively simple means. So avulsions and amputations. An avulsion is any time there's a flap of tissue made, right? So imagine a laceration that causes like a fillet. Oh, wow. Thanks for that, Andrew. Laceration.com. Gotcha. So an avulsion is any flap of tissue that comes up, right? If an entire part of a body is torn away, regardless of what part of that body is, whether it's a fingertip or an entire leg, that is called an amputation. So an avulsion is pretty easy. All you have to do is sort of replace the avulsed tissue, just flap it back in place, irrigate it out if you so desire, and then bandage it in such a way that bleeding is controlled, right? Easy peasy, lemon squeezy. Take them to the emergency department, get someone else to clean it out and suture it up, and they're good as gold. For an amputation, there's a little bit more that we have to do. So if the limb is mangled, right? If it's just like crushed to bits, that's what we call a partial amputation, right? You need to do what you can to keep that intact, right? We don't ever complete amputations. We don't just take the scissors and snip the rest of it off. It was practically all the way there. It's easier to transport in a plastic bag than trying to keep it attached to it. Don't do that. For the love of God, don't do that. We do not complete amputations in the field. You want to treat that as if it is a fracture. You splint it in place and bandage it up as appropriate. If something is completely amputated, taken right off, then we need to find the part, right? Because depending on how it was taken off, how clean it was, how recent it was, and the condition of the part, a lot of these things can be reattached. And we're talking like fingers and toes and parts of hands and parts of arms, right? There's a lot of really great centers just south of us in Boston that we can fly these people to and get these parts reattached, right? And so to do that, we have to find the part and we have to keep it in relatively good condition. And so how are we going to do that? Well, we need to keep the part cool. So I know we haven't talked about environmental injuries and frostbite and stuff like that, but what do you think is going to happen if you take an amputated body part and you throw it on ice?
Frostbite.
Yeah, exactly. So what's worse than an amputation? An amputation with freezer burn. So whatever you do, and most ambulances that I've worked in don't carry a cooler of ice around just in case they come across an organ, like you do. Um, so the best thing that you can do is wrap this thing up in gauze, throw it in a plastic bag, and put it in a cool place and try to preserve it like that. Try to keep it as cool as possible. Don't throw it directly on ice because you'll cause it additional injury. And then transport it with the patient to an appropriate facility. Try to get them to whatever center is going to be able to stabilize them first, right? Because reattaching their finger is a secondary concern to saving their life. But then once that is taken care of, the facilities to get them to a place where they can get that potentially reattached if the conditions are right. Not everything can be fixed. So wear your safety equipment. What about putting it in cool water? So again, don't dunk the part in water. If you wrap it in gauze, put it in a plastic bag, and then put that in maybe some cool water or something like that, and sort of lower the temperature some point above freezing. I mean, if you really want to know, you want to aim for around 30 degrees ish, then that would be great. But again, most ambulances that I've run on, they just don't have that available. They don't have coolers built in. The only ambulances that I've seen that have coolers have installed them for keeping certain drugs at a certain temperature, and that's usually an ALS ambulance. What's the time frame for reattachment? It depends on what was removed and how bad it was when it was removed. All right. So this is not a great example of an avulsion, but it's a great example of a contaminated wound because I'm pretty sure that's grass stuck in there. So if you can give that a little squirt of sterile saline and clean some of that out before you bandage it. Again, bleeding control comes before cleanliness. So control bleeding, of course, but if you can irrigate that out, cover it up with some sterile gauze, bandage it up and take them to the hospital, they will thank you. All right, so principles of wound treatment. In general, bruises don't need any treatment. Right? It's a closed injury. You don't need to control bleeding. It's going to do what it do. Other closed wounds should be treated by applying cold packs and gentle compression. You can also try elevating the injured part. This, if you've ever sprained an ankle, for example, this should sound very familiar. Rest, ice, compression, elevation. Although in medicine, we don't do that anymore because we've proven it doesn't work as well as we thought it did, but we still teach it. And so this is what we're looking at with bruising, right? We're going to apply an ice pack, gentle compression, elevate the injured part, and take them to whatever facility they want to go to. If it's important to stop bleeding as quickly as possible, use the cleanest dressing available. So again, if you are out in the world and you don't have your aid bag with you, you can use a t-shirt. You can use really any material that you find around you. The cleanest material possible to control bleeding will do, because it is far better to not be dead and have a little bit of a dirty wound than it is to have a perfectly clean wound in your corpse. A dressing should cover the entire wound to prevent further contamination. So again, if we think of the dressing as the white part of the Band-Aid, the white part should cover all of the wound. Don't leave any part of the wound sticking out. And then on top of that, the bandage, which holds the dressing in place, should cover the dressing completely. So cover all of the white part to prevent contamination. And so we're gonna practice this a lot the week after next. Dressing and bandaging. So again, dressings are the thing that controls bleeding, and bandages are the things that hold them in place. Remember that mummies are wrapped in bandages. That's how I remember it anyway. So bandages are the stuff that you wrap other stuff with. Dressings are what actually controls the bleeding. So you dress a wound and then you bandage the dressing. Yep. So here are some examples of dressings. You're going to see this right here, the 4x4 dressing. You're going to see that a lot. But these other trauma dressings that offer more material, you'll also see them a lot in trauma kits. So just select the appropriate dressing for the size of the wound that you encounter. And then for bandaging, really anything that holds the dressing in place. We're going to have lots of rolled gauze, but you're also going to have a lot of these triangular bandages, also called cravats. And these are great for splinting, they're great for wrapping things, they're great for building slings, and they're just a really versatile piece of medical equipment. So I carry these in my wilderness medicine packs. I obviously carry them on the ambulance. So they're great. Make sure that the dressing completely covers the wound, extends beyond all sides. Wrap the bandage just tightly enough to control the bleeding, but not so tightly that circulation is cut off. Listen, if you wanted to put a tourniquet on, just put a tourniquet on, right? We're not doing that. We're applying a bandage. And so a bandage should allow what we call patent hemostasis, right? So we're controlling bleeding, but we're allowing for circulation distally. And so in order to make sure that that's what's happening, we check for circulation before we do something, we check for circulation after we do something. And you'll see this again when we splint wounds. We're checking distal circulation before and after the skill to make sure that we haven't cut off circulation. And again, I don't need to tell you, this is something that we're going to wear gloves for. You want to keep your cooties your own, and you want them to have their diseases to themselves as well. So make sure you wear all standard precautions, personal protective equipment. So some specific stuff. The face and scalp can bleed a lot. It's very, very vascular. So because it has a large blood supply, a relatively small laceration can result in a large amount of bleeding. And if you've ever been in the room when a 3-year-old runs into the sharp corner of a coffee table, right, and all of a sudden he looks like a massacre, and everyone loses their minds because they just have blood pouring down the front of their face. When you finally get it all cleaned up, you see a 1 centimeter laceration that's probably a millimeter deep, right? Like it feels like the end of the world when it's happening, but once the dust settles, it's really not that bad. And that's just because you have a lot of really small blood vessels in your face and scalp. And so almost all facial or scalp bleeding can be controlled by direct manual pressure. So grab some gauze, put some direct pressure on there, hold it 30 seconds to a few minutes, right? And that should be sufficient to control the bleeding. Not to say that there aren't arteries in your scalp. There are. And when those bleed, it becomes quite apparent, and they need a little bit more pressure dressing, things like that. But by and large, these are nothing to be concerned about if you manage them appropriately. And so here we see someone with, that guy looks like the dude from Reading Rainbow. That's not on TV anymore, is it? Okay, never mind. So here we see direct manual pressure, and then they wrap the top of the skull there, and that bandage extends above and below. We see that the bandage is below the level of the dressing, and that helps hold it in place and prevents contamination. And then we're watching for this to soak through with blood. If it soaks through, then we need to do more to control bleeding. Inside the cheek, the major concern here is that it may interfere with breathing. So what we can do is we can hold a gauze pad inside the mouth and apply pressure from outside. So we're putting the gauze on the inside, we're holding pressure from the outside and squeeze it together, and still it stops bleeding. But always we're maintaining an open airway. And obviously be careful of sticking your fingers in someone else's mouth. I'm sure any dentist can tell you that people have a tendency to bite fingers for no reason. Scalp lacerations can be associated with skull fractures. If you have a skull fracture and you put a lot of pressure on it, then you have the potential to press sharp bone fragments into your squishy thinky bits, and that's, of course, a bad thing. So be careful, and don't apply pressure if you suspect that there's a skull fracture. With any head and neck injury, we always want to consider C-spine. Generally speaking, C-spine isn't necessary unless there was some sort of axial loading. That is a loading from the top. So think something falling on their head or a diving type injury. But we always want to be suspicious of cervical spine if there's any sort of head injury. And so as a result, just make sure that we move the head and neck as little as possible while we carefully monitor patient's airway and breathing. For nosebleeds, there's a lot of reasons for nosebleeds. We see them go up when the air is dry, and the mucosal lining tends to be a little bit more brittle, especially if you're not drinking enough water. And I'm sure we're all very familiar with the dry insides of our nose from nasal swabbing during COVID tests. So you know when you're a little bit dehydrated, when you poke around in there and it's a bit crusty. But in any case, if it's bleeding, we have to fix it. The best way to do this is to basically apply pressure and tilt the head slightly forward, right? So you want to put the patient in a seating position. You want to lean them slightly forward with their head down, and then just apply pressure and wait for the blood to clot. You pinch the nostrils together, and what you don't want to happen, right? The reason why we don't tilt our head back is that we don't want to be swallowing all of that blood, right? If we tilt our head back, it will continue to bleed. The blood will not pool. It will just drain down the back of our throat. We will swallow it, and then eventually, if we swallow enough blood, we'll get sick and vomit. Bloody noses can produce enough blood to be life-threatening, right? If you are bleeding and bleeding and bleeding and bleeding, and it is soaking towels and soaking clothes and pooling on the ground, and your patient with a nosebleed starts to have altered levels of consciousness, well, that's severe life-threatening bleeding, right? But again, do not tie a tourniquet around their neck. That will not do what you think it does. Instead, take this person to the emergency room, and the emergency room can go up in there and with balloons and gauze and nasal sprays and all that stuff, and get that stuff, get it stopped.
It's funny, I broke my nose 3 times, so I know all of that.
Yeah, did you get the balloon up there, the rhino rocket?
Yep.
Nice.
Whole 9 yards.
Nice. I've heard that those are very uncomfortable. Okay, so eye injuries. All eye injuries are potentially serious and require medical evaluation. We consider an emergent complaint a threat to life, limb, or eyesight. Right? That's generally the criteria for an urgent medical complaint. And so, obviously, this is high acuity for us. We want to transport these patients to an appropriate facility. So when an eye laceration is suspected, we want to cover the entire eye. We can cover it with a dry gauze pad loosely secured in place, or better yet, we can cover it with some kind of eye shield, some kind of rigid eye shield. What we don't want to do is to take the little ball full of jelly and squish on it, right? Because the jelly inside your eye needs to stay in your eye for it to function. It's very important jelly. And so if we put pressure on an eyeball, especially an open eyeball, the chance is that we can squeeze out that vitreous humor and basically make it so that their eye is not functional anymore. So we don't put pressure dressings on eyes. We don't put direct pressure on eyes. There's not a whole lot of blood vessels inside of an eye. There's lots around the eye, but there's nothing inside the eye. Otherwise, you'd see red. And so there's no need to put direct pressure on an eyeball. So what we do is we have these little eye pads that are gauze that we can just tape over it to sort of, just cover it up and let someone else deal with it. Or we can put a rigid eye shield over it, which definitely covers it up and lets someone else deal with it. So Tariana says, I don't do eye injuries, lol. Samesies, girl, samesies. That's why we teach EMS to cover them up and let someone else deal with it, because they are gross and there's nothing that we're going to do. So Morgan asks, do we cover both eyes or only with a puncture? That is a great question. That is not, yes, it is answered here. Okay, so occasionally an object will be impaled in the eye. Immediately place the patient on his or her back, cover, which is not always necessary. Cover the injured eye with a dressing and some sort of rigid eye shield so that the impaled object cannot move, and then bandage both eyes. So if they have a simple laceration, if you cover both eyes, the tendency is that the person will sort of just relax their vision and look straight ahead and not move their eyes around, which is fine, unless you need to move this patient around, right? If they need to, if for whatever reason, say you're on like a wilderness rescue, search and rescue type thing, and you need to walk this patient out of the woods, it's far easier for someone to walk out of the woods than you to carry them, then you're going to want at least one eye open, right? And the idea with a laceration is it's not going to significantly change the outcome of the injury. Now, the problem is if they have an impaled object and then you stabilize that impaled object, your eyes move together. And you can test this by closing one eye and putting your fingertips over your eyelid and then moving the other eye around and looking around, right? Go ahead and try it. It's weird. It feels great. You have your cameras on. I can see you not trying it. Go ahead. Do it. Give it a try. Give it a try. Close your eyes, put your fingers over your eyes, and then look around, right? You can actually feel your other eye moving at the same time, right? That is by design. That's just the way that our eyes work. The same set of nerves that make one eye go right make the other eye go right. You can't really, well, you can, but it doesn't normally happen that you can keep one eye still and move the other one around. So that creates a problem. If we have something stuck in our eye and we immobilize, and medical people immobilize that, when we look around with the other eye, what we're doing is you'll actually see that stick move around, right? And that's causing additional damage. So when we have an impaled object, we want to cover both eyes. But that creates a problem. And that problem is you've taken away the primary sensory organ of this human being. And so you're going to have to compensate by that by reassuring them, explaining exactly what's going on around them, what you're doing, what's happening, where you're going, what the bumps are that you go over in the ambulance. You need to let them know everything that's going on, because it creates a profound sense of distress in your patient, which is not good for the medicine side of things. If you have a patient in profound distress, then it changes vital signs and complicates your treatment. So you have to, when you do this, you have to make sure that you're communicating effectively with your patient. Catherine says that she can move her eyes individually. Very proud of you. Great.
I want to see that tomorrow in Walpole.
Okay, so neck wounds. The neck contains many important structures. So you have your breathing tube in the front. You have a bunch of muscles that sort of keep things upright. You have the bones of the spine and the spinal cord in the back. And then you have a bunch of really big, really major arteries going up. And you have a bunch of really big, really major veins coming down, right? And all of that is sort of packed into the area of your neck. So there's not a whole lot of your neck that isn't important. So that said, if you get big lacerations or puncture wounds, stab wounds, bits of the neck removed for whatever reason, you're dealing with a lot of potential for bleeding and potential for airway problems and potential for blood and air to mix together, which is not great. And so what we're going to do, again, all bleeding control starts with direct pressure. Once you've achieved sort of bleeding control for the moment with direct pressure, you can upgrade that to a gauze dressing or pressure dressing if that works. Or in some cases, you can use, again, one of these occlusive dressings, right? These stickers, these airtight seals that we'd use for the chest and the abdomen in case of major bleeding. We can apply one of these plastic seals to the neck, and that's been pretty effective for bleeding control, at least in my limited experience on the battlefield and doing 911. So this is, again, a method here on screen. So in rare cases, you may have to exert finger pressure above and below an injury site to prevent further neck bleeding. So again, this is sort of putting pressure on the bleeding vessel above and below. Major trauma to the neck may be associated with airway problems, especially if whatever cut the blood vessels continued on into the airway. I've got a great video of someone who was actually shot through the neck, and it goes into their neck on one side and out the neck on the other, and you can see the hole opening and closing whenever they breathe, because it just went through their airway passage and didn't really affect anything else. So it's like 30 seconds long. Maybe I'll show that in a little bit. Yep. Enough said. All right. Yeah, before we go on break, I will show you the video real quick, just because I think it's cool, and we can go on break. So you can see chin, clavicle. This is sort of looking across the neck, and you can see every time he breathes, a little bit of the air is coming out. So this is an example of a very, very small puncture wound, right, that transects the airway. And so we're not just concerned about bleeding here, but there's a potential for that blood to get into the airway itself, right? So there's a lot of potential problems that may not be manifesting right now, but that could become an issue later on. Now, fortunately, you can see this isn't bleeding a whole lot, which means it's either bleeding a whole lot inside and we can't see it, or it didn't hit anything major, right? And in this case, the latter is what happened. It just didn't get any blood vessels as it passed through. So the guy was just super, super lucky. All right. So why don't we take a very short break? I'm going to give you guys 5 minutes to feed and water yourself. Nick, you have a question?
Yeah, I mean, with a gunshot wound like that, would the bullet actually cauterize some of that?
Nah, so bullets are traveling so fast that even if they were hot, and by the time they reach you, they're not, that they wouldn't have enough time to cauterize a wound. So they just pass on through. They wreck the place, and then they just kind of keep going, like Rick James. Another really old reference there. All right, so why don't you guys take 5 minutes, come back here at 20 past, and we're going to power through the rest of these slides, and we may make it to injuries to muscles and joints. Okay, so chest and back. The major organs affected by the chest wounds and the back wounds are lungs and large blood vessels and potentially the heart. Any wound involving these organs is a life-threatening injury. So you want to place the patient with a chest injury in a comfortable position, whatever they prefer based on how they can breathe. If a lung is punctured, air from the lung can escape and be collected in the chest, between the lung and the chest wall. And this can cause the lung to collapse. If this is the case, then the patient may cough up blood. And we want to sort of correct the problem that may occur. If they have an open chest wound, we can cover that open chest wound again with one of those large stickers, plastic seals, what we call an occlusive dressing, right? It's an airtight seal that prevents the air from coming into that hole and collapsing the lung. And then we want to administer oxygen to this patient if we have it available, right? So once we seal this wound, we want to monitor the patient's airway, breathing, and circulation and treat for shock if necessary. What we expect to see is that the patient will exhibit worsening breathing, right? The patient's breathing will become more labored after you seal the wound. So we call this progressive respiratory distress, or it becomes harder and harder to breathe. And if this is the case, what is happening is every time they're breathing in, a little bit of that air leaks out through the holes in their lungs and again collects inside their chest. And so as that pressure builds up, it presses on their lung, the lung begins to collapse, it presses on their heart can't beat as well. And so we need to let some of that air out. And the way we can do that is we can peel back the edge of that seal to let some of the air out, and then put the seal back over the hole, right? So we expect that we want to seal that hole so the patient can breathe, because they can't breathe effectively if when their diaphragm tightens up, the air comes in through their chest instead of their nose and mouth, because it's not getting into the part of the lungs where it can get onto the blood cells. So we need to fix that first so that they can mechanically breathe. But after that, we know that a little bit of that air is escaping and getting trapped inside the part of the chest that isn't the lung, and we need to let that out occasionally. And so our sign that that's happening is what we call progressive respiratory distress. For impaled objects, we want to stabilize this wound with bulky dressings. So generally what we do is we take big wads of gauze, we sandwich it on either side, and then we either tape that down or wrap it or whatever we need to do in order to stabilize that impaled object. We want to move them to, a hospital preferably. And if something is, again, if it's too big to be transported, then we need to call the appropriate resources to get the object trimmed down so that we can actually fit them inside the ambulance. And then we're going to position them in whatever position they require in order to be transported, right? So if the thing is going straight through them and you can't lay them down flat, then you have to put them in, say, the recovery position or something like that. So keep in mind all of the principles that we've taught you about patient movement and keeping the spine in line and all of that, and apply that to positioning your patient. If the patient has a knife or other object protruding, again, we don't attempt to remove the impaled object because doing so can cause bleeding that we can't control. So we're going to support it. We're going to stabilize it. As you can see here, they're using the big rolls of gauze. We've got some other dressings here. They're wrapping it up and keeping it in place. For closed abdominal wounds, these are generally occurring from a direct blow from a blunt object. So either like getting hit by a car or getting hit by a baseball bat or a charging bull moose. I don't know. Look for bruises and other marks on the abdomen that indicate a blunt injury. One of the examples of this that you may see is what we call seatbelt sign, which is someone who is wearing their seatbelt maybe a little bit too far up on their abdomen. And when the car comes to a sudden halt, we see that seatbelt causes some blunt injuries across the abdomen. And we can see that in the form of a bruised stripe going across their abdomen or going across their chest. So that's a pretty common sign. So whenever a patient is injured and experiencing shock, that there may be some sort of internal bleeding associated with that, whatever that injury is. So in the case of the abdomen, we're seeing the abdomen become swollen. It will become rigid to the touch, right? And in some cases, it's described as hard like a board. These patients are treated by placing them on their backs. You can elevate their legs if indicated by protocol. That is not something that is indicated in New Hampshire protocol because it's not based on science. And then always keep them warm. really one of the more important treatments for shock at the basic life support level is to make sure that they do not lose heat. If the patient is vomiting, it may be an indication of bleeding in their gastrointestinal tract, so like the stomach or esophagus, stomach filling up with blood. If they vomit, then a lot of times they'll vomit up what appears to be blood or clotted blood. So in that case, we want to support their airway, suction if necessary, monitor vital signs. Obviously, don't feed and water this patient, and get them to a hospital as soon as you possibly can. For open abdominal wounds, these usually result from some sort of slashing or cutting object, right? So anything from a plate glass window to a machete fight in downtown Manchester. Whatever the case, the threat here is that they cut through the muscle portion of the abdomen to the intestines, which then allows the intestines to spill out. And so the inside of your body is pressurized, right? There's a lot of stuff holding your organs in, and once that's opened up, the tendency is for all these things to spill out. The few times I've seen an actual evisceration, which is the intestines coming out, it's usually been through a relatively small cut. Generally, unless someone is like committing ceremonial suicide by Japanese sword, we don't see all of the guts spilling out. But in any case, what you don't do is try to put the intestines back in, right? Once they're out, they're out. And we are not going to reintroduce any contaminants or bacteria because it's really hard to get in there and wash everything out inside the abdomen. So instead, what we're going to do is cover the injured area with a sterile dressing, and they make abdominal dressings, and these things are enormous, right? So you want to cover the entire area with a sterile dressing. Don't attempt to put them back inside. And then ideally, you want to soak these dressings in sterile saline, right? So in the ambulance, you have sterile saline in bottles as part of the required equipment for licensing. So you want to soak these large abdominal dressings in sterile saline to try to keep these organs moist. And then in addition to covering them up, you also want to put some sort of insulating layer. So whether that's saran wrap or tin foil or whatever they have on the ambulance, maybe none of that, but you want to try to keep this as warm as possible so that they don't dry out and the patient doesn't become hypothermic, because these guts are going to be like a radiator. They're just going to waste all of that body heat out into the environment. So here we see a patient with an evisceration. You see some little loops of intestine coming out here. And so what they've done is they've brought the knees up, which decreases the pressure inside the abdomen, right? So it makes all this skin here loose. If you have belly rolls, then that's the position you want to be in, because belly rolls means that the skin is not under tension. And so then they place this large abdominal dressing over it. They place some sort of insulating pad over that, right? So this looks like a sheet of plastic or saran wrap or something, and then they bandaged it all together, right? And that is the appropriate treatment for an evisceration. Wounds to the genitalia. Both male and female genitals have a rich blood supply, so injuries to these areas may result in severe bleeding. But again, it's like the scalp. A small cut can produce a lot of bleeding, and then especially considering the area, people are generally very concerned with what's going on down there, especially when it's their own. So again, apply direct pressure, dry sterile dressing. Although it may be embarrassing to examine the patient's genital area, you need to do that to determine the extent and severity of the injury. Okay, thanks, Nick. The consequences. So, and hopefully we'll never ever see this stuff, right? But my experience with trauma to the genitalia comes from a lot of people stepping on landmines, right? because there's an explosive mechanism, and generally landmines will take someone's leg and turn them into a superheated ball of shrapnel, which then projects rocks and metal fragments and bone fragments that used to be this person's leg up into their abdomen, generally through their genitalia. We also see when people roll over roadside bombs and they're sitting down, that their buttocks and their genitalia can be taken off by shrapnel, explosions, explosively formed penetrators and stuff like that. And so what I've seen is that someone will look normal laying on a stretcher, but as soon as you turn them over, they have this massive bleeding cavity that used to be their buttocks and genitalia, right? And so you have to turn them over and inspect the back. You're not going to find these injuries if you don't. And then you also have to be ready to sort of get in there with aggressive bleeding control. In this case, it involved a lot of wound packing and just sort of finding the sources of bleeding and trying to figure out how to hold direct pressure against them. Now, fortunately, very, very fortunately, we happen to live in one of the few countries in the world that doesn't experience warfare on a daily basis, and I really hope it stays that way, because let me tell you, explosives are really not what we want to be working with in EMS. So moving on to other things that I've done a lot of. So extremity wounds, generally speaking, you're not going to come across a lot of amputations. You're not going to come across a lot of gunshot wounds and explosions. So the cool stuff is not what you're going to work with. By and large, there are going to be a lot of minor lacerations and sort of the consequences of poor decision making. And so what do we do for these most often? We're going to apply direct pressure. We're going to put on a dry sterile dressing. We're going to escalate our level of bleeding control based on how effective our interventions are working. And then we're going to, if we think that there's any underlying fracture, we're going to apply splints. And then we're going to transport them to an appropriate facility. So here we see direct pressure. We see a pressure dressing. So if you imagine that if this didn't work, we put a big bulky piece of material under this. We wrapped it up. And then here we see someone using roll gauze to wrap a leg, and that's great too. This person obviously spilled ketchup on their leg. That was probably their bad decision. I've been called out for worse. So gunshot wounds. So most deaths from gunshot wounds result from internal blood loss caused by damage to internal organs or major blood vessels. Prompt and effective treatment for these wounds is important. Gunshot wounds to the trunk and neck are actually, they're not a major source of spinal cord injuries. We took a hard look at this in the military and found that unless you actually shoot someone's spine, you don't really see a whole lot of that. And in fact, putting a C-collar on someone with a neck wound from a gunshot, we found prevents people from effectively treating the bleeding and the other things that are actually going to kill someone. So that's not true. Because you can't see the bullet's path through the body, you should treat these patients for spinal... Okay, all right, moving on. That's not true. To treat a patient with a gunshot wound, follow these steps. Open the airway. Establish adequate ventilation and circulation. True. Control any external bleeding by covering wounds with sterile dressings, applying pressure dressings, either with your hand or a bandage. Examine all the patient's wounds, or examine the patient's body thoroughly to locate all entrance and potential exit wounds. Not every entrance will have an exit. Sometimes a body will enter the body and sort of bounce around for a bit and come to a rest inside. And you can never tell what it bounced off of. So just because they were shot in the leg doesn't mean that that bullet didn't find its way up into the lungs. So be prepared for any sort of sign or symptom of shock, right? So be prepared to treat for shock. Administer oxygen if available. Arrange for prompt transport. And then if the patient loses their pulse, then obviously we need to start performing CPR. All right, so bites. Bites from animals or humans may range from minor to severe. All bites carry a high risk of infection. Human bites are actually at highest risk of infection unless the animal has rabies, because human mouths are objectively dirtier than most animal mouths. But bites from unvaccinated or wild animals may carry diseases such as rabies, which needs prompt intervention. Minor bites can be washed with soap and water, generally speaking, but major bite wounds need to be controlled as open wounds, right? So it doesn't matter what caused it. If you have just like gnarly flaps of tissue, you need to find the source of bleeding, control the source of bleeding, transport to the hospital. In a lot of states that you're required to report animal bites to local health department or law enforcement. Generally the same for human bites as well. I would definitely report a human bite to somebody. But with animal bites, you have to specifically notify local health departments because there's a lot of zoonotic diseases or animal-borne diseases out there, and that's important to track. All right, so getting into burns. Before we get into burns, does anyone have any questions about the stuff we covered about soft tissue injuries? Morgan has spoken for the group. She says no. No one has any questions. Thank you, Morgan. Someone needed to step up. All right, so let's talk about burns. So the skin is an important organ. It serves as a barrier between your insides and the environment. It prevents foreign substances from entering the body and is roughly watertight and just generally great. And so it prevents us from losing our inside fluids to the outside. And when it's damaged, it can no longer perform these essential functions. And so some of the damage that we can do to skin is we can burn it. And so we generally classify burns by the depth of their how far they penetrate into the skin. And remember that skin is composed of layers: the epidermis, the dermis, and the subcutaneous tissue. And then under that we have like muscle and bone and stuff. So our first burn is what we call a superficial burn. This is commonly referred to in like first aid literature as a first-degree burn. But these are characterized by reddened and painful skin. And so this is pretty much me on any sunny day. I make the transition from porcelain to lobster just by walking from the store to my car across the parking lot. And so I'm sure a lot of us are very familiar with this. This injury is confined to the outermost layers of the skin and generally minor to moderate pain. And it will normally go away in about a week. Below that, we have what's called a partial thickness burn. This is also referred to as a second-degree burn, but in medicine, we call it a partial thickness burn. This is somewhat deeper, but doesn't really reach down to the deepest layers of the skin. This is where we start to see the formation of blisters. Blisters are pockets of fluid from the body that contain immune cells, right? So these are the parts of your immune system that are breaking down damaged skin and digesting it and rebuilding parts of your tissue. And so blisters actually serve a function, right? They are regenerating the skin underneath. So with this, there may be some fluid loss depending on how big those blisters are, right? Because that fluid has to come from somewhere. And then these are generally more painful because they reach down further and they connect with more nerve endings and will cause more pain. So again, with the more damage to the skin, we see a longer healing time, generally 2 to 3 weeks. And then we get to what we call full thickness burns. So these are burns that go through the epidermis, through the dermis, and into the subcutaneous layers. And these are also known as third-degree burns in the first aid literature. But again, in medicine, we refer to this as a full thickness burn. So in the areas of third-degree or full thickness burns, we often see that the nerve endings are just burned away. You don't have any sensation. There's nothing there to send a signal of pain. However, areas of full thickness burns are often surrounded by partial thickness burns, that that are intensely painful, right? So just because someone has third-degree burns doesn't mean that they aren't in severe pain. These patients are just in astonishing amounts of pain, generally speaking. Because the skin is entirely burned away, these patients present with large quantities of body fluid lost, and they are susceptible to shock, massive infection, lots of complications down the line from this massive cascade of hormone release, things called cytokines that maybe you've heard of because of COVID, but just like your body just goes haywire with these burns. These should be considered open wounds. Just imagine someone took a cheese grater and just grated off all of their skin and they were just one big massive open wound. That's basically what you're looking at with these full thickness burns, right? And so the important thing to remember with burns is that the burn itself is not life-threatening. The thing that caused the burn may be threatening their life. So please, if your patient is on fire, extinguish them before beginning treatment. That definitely counts as a life threat. But the burn itself isn't going to kill the patient. Any trauma caused to the patient will kill them, and so you need to manage that. Collapse of the airway, breathing, circulation will kill the patient, so you have to manage that. And then eventually, down the road, a massive fluid shift and a massive inflammation and infection will kill the patient, but that's not something that you can manage, right? So any intervention that you can do through normal skin, you can do through burned skin. So make sure that you focus on the things that are actually going to kill them. Now, before we continue, so Danielle asked, isn't there a 4th degree burn? So there is something that is sort of colloquially known as 4th degree burn, and this is beyond full thickness. So what comes after all the way, right? And so you can only burn down to full thickness, which is all the layers of your skin, before we don't have a classification for the depth anymore. And so this 4th degree burn involves the burning of muscle and bone tissue. So you're literally incinerating part of the body, right? And so again, we will treat this as an open wound because that's effectively what it is. If you've incinerated away a part of the body, then we're sort of getting into the territory of like avulsion, amputation sort of situation. All right, so moving on to categorizing the extent of burns, right? So we use the rule of 9s, and this is a super complicated thing that we ask people to remember, and I couldn't even tell you the rule of 9s with any degree of certainty. I can tell you that in my medical practice, I keep with me a chart, and I reference the chart when I have burns, and so here we have the chart. And this is super useful to keep with you in the ambulance, in a flip book, whatever you have. But the basic premise here is that you can divide body surface area into segments of 9%. And so the front of the arm is 9, the back of the arm is 9. The front of the chest is 9, the back of the chest is 9. The front of the abdomen is 9. The back of the abdomen is 9. Or the small of your back is 9. The front of the thigh is 9. The back of the thigh is 9. The front of the lower leg is 9. The back of the lower leg is 9, right? So we've roughly divided the body surface area into these groups of 9, right? And so 9 times 11 is 99. What happens with the other percent? Well, the other 1% is a really important 1%, right? And so what we see is that if you have burns to the genitalia, that counts as an emergency, and we have to transport that person emergently. But any surface area greater than 20% is an emergency, generally speaking. Burns to the face and the airway is an emergency, right? And then burns to the digits and other structures. I already said the face, so like nose and ears and fingers and toes. Those are generally of higher acuity because those burns will limit your ability to use your digits later on. So they'll require rapid test rapid treatment and occupational therapy. So going back to the rule of nines, this is for the adult patient. For the children, the rules of nines is modified. And again, this is all. I don't expect you to remember that a child's leg is 16.5%. And Danielle asked the real question that we all have, right? Real talk from Danielle. Will this be on the test? That is a great question. It will be represented on the test in a non-numerical form. So you're not going to be given a description of someone's burns and asked and be required to calculate body surface percentage, but you will be asked to know that the rule of nines is the system that you use to calculate body percentage. Now, the other thing that I want to tell you about is the Palmer method, which is that the palm of the patient's hand represents about 1% of their body surface area, right? So that is another handy method of determining body surface area burns. All right, so causes of burns. Thermal burns caused by thermal stuff, heat, right? So what do we want to do? We want to stop the burning process. And I don't mean if your patient is on fire, extinguish them. That is expected. Please extinguish your on-fire patients. But also, once you put these patients out, they're still hot. I remember showing up to a call once, and the patient had already been brought out of the burning building and had already been bandaged by first responders on scene. I peeled back the gauze that they used to cover the wound, and the gauze was singed on the inside because no one had stopped the burning process yet. The flesh of their body was hot enough to toast the gauze, which is definitely suboptimal. If you've ever cooked a turkey, you don't cook it all the way, right? You cook it to a certain point, and then you take it out of the oven, you let it rest. What's it doing when it's resting? The heat is spreading out through the meat, and it's continuing to cook, right? We take it out and let it rest, and we don't cool it off because it's still cooking. People do that too. People are made of meat. And so when you cook a person in a burning house, they continue to cook, right? We don't want to take them out and let them rest because we're not trying to eat them. That is illegal in most places. What we want to do is we want to stop the burning process, and in a lot of cases that means taking your sterile water, sterile saline, and irrigating the area to make sure that it is cool before we start treating the burn wound. And this is basic first aid. What do you do when you burn your finger? You run it under the faucet, right? So this shouldn't be new to anyone. We're just sort of translating it into medicine. Now we want to cover these things with dry, sterile dressings, right? So we don't cover them with burn sheets have fallen out of favor. We don't carry burn sheets on ambulances. They're not a medical intervention, right? We're not going to use a burn sheet on an ambulance. We're going to use dry, sterile dressings. But we don't wet these dressings. As much sense as that would make in your mind, don't cover it with a wet dressing because the wet dressing will dry out, and then when you peel it off, it will tear away the precious remaining skin that they have available. So dry, sterile dressing. If there's blisters, don't break the blisters because remember, they're filled with good stuff that's healing the skin underneath. And then patients with large burns, we would expect them to go into shock. So we have to keep an eye on that. For respiratory burns, New Hampshire doesn't allow burn pads. Yes, that is, I guess, what I was trying to say. They're not on ambulances. You don't get licensed as an ambulance if you have big orange buckets of burn pad. In fact, in most industrial facilities, they're getting rid of those because they're no longer something that is supported by OSHA or anything like that. It's one of those things where like we thought it would work because it sort of makes sense, I guess, if you don't think about it or apply any sort of investigation or science. But the moment someone applied some science to it, they're like, nope, this is not only not doing what we thought it was, but it is potentially harmful. So just don't do it. So respiratory burns. So the problem with a burn is that it is an insult to tissue. And what happens when you insult tissue? It swells up, right? And so what happens when your airway swells up? Well, you can't get air through it. And that's bad for an airway. So for respiratory burns, we're looking for signs and symptoms of burn around the nose and the mouth. So that's like singeing of any hair that they have on their face, soot inside the mouth. If the swelling has already started, you're going to hear that stridorous upper respiratory noises, those squeaky respirations. They may complain of difficulty breathing. And then obviously if they lose consciousness, whether it's from burning of the airway, swelling of the airway, inhalation of carbon monoxide or cyanide from the smoke, then we need to treat this person aggressively. So they can go from being okay to being very not okay in a pretty short amount of time. So we have to anticipate these complications, and we need to be aggressive in our management leading up to the point where this person is no longer breathing. So one of the first things we want to do is get an ALS ambulance on the way, because those paramedics, whether they're comfortable with it or not, they can cut open a hole in the throat and put a breathing tube in it. Or if they get there fast enough, they can slide a breathing tube through their rapidly collapsing airway, right? But they need to get there soon, because once this airway slams shut, you're not fitting anything through it. And so then requires them to cut open the neck, which a lot of people aren't comfortable with. So get ALS on the way as quickly as possible. Administer oxygen. You want to get as much oxygen in this person as possible before their airway shuts off, right? Not only because they probably are loaded up with cyanide and carbon monoxide, which disables your red blood cells from carrying oxygen, and you want to flood them with oxygen and wash away all that nasty stuff, but you want to just get up their physiological reserves of oxygen just in case someone doesn't get there in time. And then these people need to go to the hospital immediately, because there's no one you want cutting a throat open more than an emergency physician, because they do it professionally. Chemical burns. So there are lots of strong caustic substances used in industry. These are strong alkalis, and in some cases strong acids that will cause significant burns or may even melt tissue away. These are bad. In most cases, they'll cause some irritation. They'll be very painful, and they can be transported for damage, sort of superficial damage. But in some cases, the depth of these chemical burns goes quite deep, and causes a lot of damage. And so, really, our primary concern is our own safety. We don't want to compete with our patient for care. So make sure that we decon. We want to make sure that we decon. We want to make sure that, okay, so Nick dropped chlorine, ammonia, and HF. And so if someone is burned with chlorine, well, they used that in World War I to kill people, so we don't really want to go into that place without appropriate PPE. The same with ammonia. Ammonia can be overwhelming. And so we want to make sure that we are safe first, and then we want to decontaminate the patient as much as we can before we package them and transport them. The other thing that you dropped in the chat, in case anyone's paying attention, is hydrofluoric acid. This is by and large not... It's losing favor because the benefits of using HF for a solvent are far outweighed by the tremendous damage that it does. And you don't actually get a chemical burn from hydrofluoric acid. It actually is immediately absorbed into your bloodstream, and it kills you in interesting and painful ways. And so a lot of the hydrofluoric acid that you can buy is really dilute, and it takes you a long time to build up the levels of HF so that you cause cancer and die. But you can find concentrated hydrofluoric acid once in a while. And I actually recorded a whole podcast about this. If you guys are super nerdy like me and you want to know more about interesting ways to get poisoned and die, I have a podcast about that. You can ask me about that later. So how do we decon people? We want to remove as much of the chemical as possible. If it's a dry chemical, we want to brush it away without contaminating ourselves. If it's not a dry chemical and they're already in the showers at their facility, we want to flush them with like as much water as we possibly can. And no, we're not talking about a couple Dasani bottles. We're talking about like swimming pools worth of water. And then once they're deconned like that, we'll cover with dry sterile dressing, just like a normal burn, and arrange for prompt transport. If they get chemicals in their eyes, that's obviously a bad day. Again, copious amounts of water. We want to flush this thing for at least 20 minutes. Make sure they open their eyes. They may be hesitant to open their eyes because it burns. And also holding your eyes open under flowing water is sort of a counterintuitive thing. But get them to open their eyes. If they can't open them themselves, and hold their eyes open. And irrigate with large amount of clean water. And then again, we treat this the same way we treat any eye injury. Cover it loosely with gauze bandages or cover it with a rigid eye shield and transport. Electricity, another thing where our safety comes first. Don't compete with your patient for care. All right? You don't want to run in and save your patient if the electrical company hasn't turned off the electricity, because you will just become another victim. So once the electricity is off, you can go in and start assessing. The tricky thing about electricity is that it always finds its way to ground, and your body represents a great pathway from charge to ground. And so it'll enter through a hand, it'll travel through all of your organs, and then exit out through your feet, and now you're down a few organs. They're cooked. They're cooked from the inside out, and they cannot be replaced. And so that's how you die from electrocution. Now, you can get electrocuted with lower amperage, lower voltage stuff like household current, and that's not going to blow a hole in you like a high tension line would, but it can cause disturbances in your cardiac rhythm, so it may stop your heart. So in any case, once you get that power turned off, you're doing your same ABC assessment. You're checking for a pulse. If there is no pulse, you're going to start CPR. If there is a pulse, you're going to provide supportive care, as long as you are safe, right? And then finally, multi-system trauma. So just as the name implies, multi-system trauma is trauma to more than one system of your body. And so you're not expected to go through and diagnose all of your patient's injuries, right? As an EMR, you don't have the depth of anatomy and physiology and the kinematics of trauma and all of this other stuff in order to do that. So you're not expected to do it. What you're expected to do is use a systematic method to assess your patient, find the things that are killing them, and correct those things while greater levels of certification and more resources are coming to the scene, right? You don't have to worry about being a doctor on scene, because you're not. You are an initial lifesaver. You're going to apply treatments to airway, breathing, and circulation and stabilize this person, while somebody else with a greater amount of training is going to come in and do their paramagic, right? So don't get overwhelmed by this. Those are my words of wisdom. Don't get overwhelmed. Use a systematic method of assessing and treating these patients, and you'll do fine. So let's summarize now that we've hit the top of the hour. So this chapter covers a lot of knowledge, and we're going to work on the skills over the next couple weeks, but a lot of knowledge to treat patients who are experiencing shock, bleeding, and soft tissue injuries. We covered all of trauma in 4 hours, which is just phenomenal. You have to take body substance isolation precautions, especially when people are leaky. The 3 parts of the circulatory system, the pump, the pipes, and the fluid. And we talked about how those work and how they stop working. We talked about a shock state as being a collapse of the cardiovascular system that results in inadequate delivery of oxygen to the tissues. The 3 primary causes of shock are pump failure, pipe failure, and fluid loss. And the general treatment for shock is positioning the patient, maintaining the ABCs, and then treating the cause of shock if possible. We also want to keep this patient warm. 3 types of external blood loss are possible. We have capillary blood flow, which is the most common, venous bleeding, which is not as common and not the most dangerous, and then arterial bleeding, which is the most dangerous. The most external bleeding can be controlled by applying direct pressure to the wound. A wound is an injury caused by any physical means that leads to damage of a body part. Pretty easy. We classify this as either open and closed. Open wounds are bleeding. Closed wounds are not. Control bleeding by covering an open wound with a dry, clean, sterile dressing. Apply pressure to the dressing with your hand. You can add additional material to create a pressure dressing. If you think that the amount of bleeding is life-threatening, you can skip directly to a tourniquet. We talked about burns. There are 3 classifications of burns based on depth. We have superficial, partial thickness, and full thickness. And again, these are sort of referred to by the lay rescuer as first degree, second degree, and third degree. And we know that these burns can be caused by heat, chemicals, or electricity. So I'm not gonna keep you over. I'm gonna respect your time, so we won't do the review questions. But if anyone has any questions for me, please ask. If not, you are free to go. So any questions about anything that we've covered so far? David says, blow out the flaming shot before you drink it, then take a breath. Proper sequence and timing is what we call that in the aviation industry. Wise words. All right, so as folks are, oh, yeah, the hydrofluoric acid. So, I don't know if I want to post this on YouTube, but I put the website address in the chat. So if you go there, you'll see all of the episodes, and super nerdy. You listen to me talk more. It's on you. All right, so as everyone is exiting, anyone sticking behind, let's go through these review questions. So which of the following statements regarding standard precautions is true? Standard precautions assume that all body fluids are potentially infectious. Standard precautions assume that some body fluids are potentially infectious. Standard precautions apply to paramedics who perform invasive procedures. And EMRs are only required to wear gloves to comply with standard precautions. And the answer is A. That's right. Everything is infectious all the time. Appropriate management of impaled objects in the eye includes bandaging only the affected eye, rinsing the eyes with saline, bandaging both eyes, or removing the object to prevent further damage. Yes, exactly. And patients with full thickness burns generally do not complain of pain. Incorrect. Because blister formation protects the burns, nerve endings have been destroyed, deep burns produce a natural painkiller in the patient's system, and the patient is generally not conscious. So if that were true, it would be B, but it is not true because remember, third-degree burns are surrounded by second-degree burns, which are intensely painful. Absolutely. All right, so does anyone have any questions? I'm going to stop recording here.